Okay, hello, good evening. Today we will complete Fawzia sheet 2 recalls from question 91 till the end of the recall. Start with Dr. Khadija. Okay, Dr. Khadija, you can start.
Okay. We are starting from question number 91. Which of the following statements is
Yes, exactly.
Which of the following statements is true with relation to cardiac muscle? When the question tells which one is true, we only see the true answer, the only answer which is true.
Exactly.
Is a contraction is triggered by an influx of calcium ion through the sarcolemma. When calcium ion enters into the sarcolemma means muscles covering of cardiac muscles. When calcium influx, there is it triggers the muscle contraction. It's related to cardiac muscle.
Exactly. So the contraction is triggered. Yeah, this is a physiology question. Contraction is triggered by influx of calcium through the sarcolemma. Okay.
Number 92. A 39-year-old man presents with sharing left-sided loin to groin pain. Investigation reveals a radiodense opacity confirmed to be in the ureter on the intravenous urography. What is the most likely composition of this man's ureteric stone? It's calcium oxalate stone. Calcium oxalate stone, if we do the imaging, it is radiodense and radiodense opacity. That's what
radio opaque opacity.
Radio opaque.
Okay. According to renal stones, the most opaque is, keep it, the most common one is
calcium oxalate.
Calcium oxalate stone.
Calcium phosphate.
Okay, let's go. We have most common. Most common. Calcium oxalate. So if he didn't mention anything here, he just mentioned, if he didn't mention, okay, a man is converted with a ureteric stone. What is the composition of? So he is asking about the most common. Okay, this is a radio opaque, but what is the most radio opaque? Calcium phosphate, most radio opaque. Okay, radiolucent.
Uric acid.
Uric acid stone. Okay, and the common with patient has a protein destruction or patient taking chemotherapy. Sometimes it is tell you this patient is taking chemotherapy and he has a protein breakdown. Okay, and amino acid breakdown. So amino acid, so uric acid stone are very common in this patient. Okay. What is the most common hereditary spoon?
Strophe.
Cystine.
Cystine stone. If there is a family history of hypercystinemia, so this will be cystine stone is very common and has a genetic defect. Okay, still the Sturvet stone, the most common one in the renal pelvis and associated with recurrent infection. Okay. If you read this, can someone read this, please? Okay, clear about this? Most common calcium oxalate, most radio opaque calcium phosphate, radiolucent uric acid. Hereditary factor is cysteine. So if you tell his father has a stone or family history of stones, so this cysteine stone, stervate is related to infection. Okay, yeah, someone can read this table, please.
Calcium stones are radio-opaque. Oxalate is the commonest. Phosphate, hydroxyapatite.
Okay.
Phosphate is the most opaque. Most radio-opaque is phosphate, and oxalate is the commonest. Uric acid stones are radiolucent. Struvite stones are made of magnesium, ammonium phosphate.
Forget about.
Okay. It's common in female due to UTI with urea splitting bacteria, mostly can form staghorn calculi. This is
very common. This is Petrus mirabilis.
Wait, okay, struvite forms a staghorn and associated with the alkaline urine. Cystine stone cystine stone is due to genetic defect causing cystinuria. There will be a family history, it is hereditary.
Okay, this is the most common question, and this is the most common question about the most common stone is the calcium stone and the stervate stone. All of them sometimes come. Okay, and this is, I think, very simple to know. The next question.
Number 93, a 25-year-old man is playing football when he complains of posterior thigh pain while sprinting with ball. On examination, he has tenderness in the lower lateral posterior thigh. He is unable to fully extend the knee due to pain. What is the most likely injury? It is the hamstring muscle injury, posterior thigh. Biceps femoris tear is the answer. Biceps femoris tear. Biceps femoris muscle is the lateral posterior thigh, and there is history of strenuous activity like sprinting, ball, heavy sport injury. There is hyper extension or hyperflexion of the hip joint. That's why this tear.
Okay, so the lower lateral posterior, this is an anatomy question. I want to know if you know the lower lateral posterior side is the biceps and the hamstring on the other side. So this is a type of biceps and very common to have biceps femoris tear. Okay.
Number 94, a 23-year-old man is assaulted and sustains a stab injury to the left groin. The wound is cleaned, a simple dressing applied. 6 months later, patient returns with a pulsatile swelling in the site of injury. The most probable lesion present is abscess, false aneurysm of femoral artery, lymphocele, mycotic aneurysm of femoral artery, saphenopharynx. If there is abscess, the patient will be present after 6 months, so long. And the injury is in the groin area, and the swelling is pulsatile. We can assume it's arterial origin. So false aneurysm of femoral artery is the correct answer.
Okay. Okay.
And I don't know about mycotic aneurysm of femoral artery. I don't have any idea. It's false aneurysm of femoral artery.
There's repeated question from the last one. Okay, so this type of aneurysm happens due to mycotic infection. Okay, saphenopharynx, it is not saphenopharynx, this is pulsating. And this is post-trauma. As we said before, we have a big station in part to be about patient with multiple trauma, even sometimes with multiple injectable trauma. Like patient are making renal dialysis or making an intravenous drug abuser, IVDU. Patient, all this with multiple trauma to the vessel can have a false aneurysm of the artery. Repeated from Fawzia sheet 1. Okay, next question.
95, a 12 years old girl has a diastolic murmur It is maximally audible in the second left intercostal space. Which structure is the most likely cause of this pathology? Second left intercostal space, there is pulmonary valve, so the pathology will be in pulmonary valve.
Okay, what do you expect here? It is what is the pulmonary valve problem here? It's a diastolic murmur. This is stenosis or regurg?
Stenosis.
Regurg.
Be regurgitation.
Regurg. We said, okay, just to remember it again. Diastolic. Systolic. Diastolic, the blood come back during diastole and dilatation of the heart. So some blood will come to the heart. Okay, normally some will be back through the valve. In diastolic, type that هتبقى confusing for you. Type confusing. Okay. We have the mitral valve. The mitral valve. This is the heart. I have the mitral valve, and I have the pulmonary, the aortic, and I have the tricuspid, and I have the pulmonary. Keep one only. Keep one only. Okay. This is the mitral and this is the aortic. Okay. Direction of blood during systole. This blood direction normally like this, and this drug and this blood direction is normal like this. If I have a systolic murmur here during systole, what will happen? During systole, the blood should go like normally like this, and here should be blocked and should be never blood go like this during systole. If I have systolic murmur on the mitral valve, what should be? Normally should be no murmur, but if I have a systolic murmur,
Regurgitation.
Okay.
Incompetent valve.
Incompetent valve. Incompetent valve. This is incompetent valve. Okay. Okay. Keep this because here's the most common. And this it was confusing to the last group. I have the mitral valve. Normally blood going like this. If I hear a systolic murmur on the mitral valve, because this is the aortic valve, to be easy for you. I just don't want to confuse because all of you. I have a systolic murmur on the aortic valve. That means that normal blood going like this, and I'm hearing a murmur. So I have stenosis. Normally the blood can go. Normally the blood can go without any noise, without any simple, without any problem. If I have stenosis, there will be ejection, systolic, murmur. Ejection systolic murmur. So if I have an ejection systolic murmur here, so I have mitral stenosis. During diastole, aortic valve should be closed. Aortic valve should be closed, and the blood is coming like this during diastole of the heart. So the valve will be like this, should be closed. If I hear a diastolic murmur on the aortic valve, what should be?
Aortic regurgitation.
Aortic regurg. Aortic regurg. Okay. So if I systolic, it will be ejection systolic murmur. Ejection systolic murmur, because there is narrowing here. So I feel like ejection systolic murmur. During systole, there is obstruction of the blood flow through the aorta at the valve. But during diastole, should no blood come back through the aortic artery. But if I hear there is some sort of regurg and weakness here, so it will be regurg. Okay, the same we said with systolic, it will be ejection systolic murmur. With diastole, it will be regurg, aortic regurg. The same with mitral valve. The blood come from the blood come from the left atrium through the valve, normal. If I hear a cyst, this will be diastolic murmur. I get confused in this point, please. What comes again to be recorded? What comes in aortic valve? Problem. He tell you ejection systolic murmur on the second right intercostal space, and he asks you about what is the pathology? Aortic valve. What is the valve? Is the aortic valve, and what is the pathology? It aortic stenosis. I can't remember he bring aortic regurg anymore because it's very rare. Aortic stenosis, and this is the most common. This is one question in the exams. Other question, he tell you audible murmur on whatever, systolic or diastolic, on the second right, second left, fourth left parasternal, or fifth mid-clavicular right, mid-clavicular line. And he asks you what is the valve. As we know, aortic, pulmonary, tricuspid, and mitral. Okay. Only one question in the exam. Don't worry about it.
Sir,
Yeah,
in that
continue.
question, excuse me, sir. In that picture, there's a area number 3 herbs point. Do we have to remember?
Forget about it. Forget about it.
Okay.
Forget about number 3. It's complete. It is not. It's out of our scope.
Okay. Number 96. A 25-year-old man is admitted having been stabbed in the interior chest. On examination, he is alert and coherent. He has congested neck veins. His pulse is 140 beats per minute. and his blood pressure 90/60 millimeter of mercury. He has normal breath sounds. What is the most likely cause of his cardiac arrest 15 minutes later? Cardiac tamponade, congestive cardiac failure, hypovolemia, tension pneumothorax, ventricular arrhythmia. Here is the answer is cardiac tamponade. Cardiac tamponade is the reason of his cardiac arrest. It will be, but I don't know the mechanism. You can explain.
Sorry.
I
Cardiac
don't
tamponade?
understand the cardiac tamponade.
You don't ask. What is cardiac tamponade? It is hemopericardium.
Hemopericardium, yes, blood in the pericardium.
Pericardium.
Even if
Just like
small amount, less than 100 ml, is enough to cause
out of our scope.
Problem.
Out of our scope. Out of our scope. Okay. We have only cardiac tamponade in without any details. Cardiac tamponade without any details. Cardiac tamponade will give you the picture of fixed triad. Fixed triad. Hypotension, congested neck veins or jugular venous distension, and muffled heart sound, distant heart sounds. Okay, in patient with hemopericardium or cardiac tamponade, we don't have degrees. It is out of our scope. We have only the simple common picture. What will happen? Stab or motor car accident, and the patient came to the ER. You have heard muffled heart sound with auscultation, and he has congested neck veins, and the patient has hypotension. So this patient has bleeding inside the heart, and so the heart will be congested and be restricted, and so the blood coming from the superior vena cava with its branches, which is the jugular vein, can't go inside the heart. So this patient will have congested neck veins. What is the importance about this? Normal, I tell you here, normal breath sounds.
To exclude tension pneumothorax, possibility of tension pneumothorax.
In tension pneumothorax, there will be absent breath sounds.
Why he excluded this? To make it clear for you. Okay. Any patient okay. Patient has stab chest. Patient has a stab chest. Okay. You have two possibilities of bleeding. Patient have a stab chest, and he told you here in the have been saying this is in the anterior chest. This is anterior chest. Okay, will it changes? This is anterior chest. I'll give you the picture of hypotension. 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 What's the possibilities the patient have? Bleeding inside pericardium. How?
Bleeding into pleural fluid.
Pleural bleeding. Patient has hypotension, so the patient has bleeding. The bleeding may be here around the heart, or the bleeding may be here on the pleura. So the patient can have hemopellular or hemoffusion, or the patient has hemopericardia. Then he told you the patient has congested neck veins. In hypotension patient patient with hypotension, normally you found the neck vein sometimes empty because there is decreased venous return. Okay, decreased venous return. So if it is in the pleural hemorrhage, what you'll find? Empty neck veins plus decreased breath sounds. Okay. If the bleeding in the pericardium, what you will see? Congested neck veins plus muffled heart sounds. Here is will be, I can see here muffled breath sounds, but here is muffled heart sounds and normal breath sounds. Let's make it here shifted cardiac pulsation, but will be normal. You see the difference between chest trauma, stab chest trauma? That's why he tell you here normal breath sounds and congested neck veins. He gave you the big triad of cardiac tamponade. In another question, I think in EMRCS, and I think in trauma and the emergency, he gave you the patient is trauma to the chest, stab trauma to the chest. The patient is hypotensive with decreased breath sounds and decreased jugular venous pressure or low CVP. This will be
tension pneumothorax.
Hemothorax, not tension hemothorax. Not tension. Okay, tension hemothorax is not common. Keep it hemothorax. Hemothorax. Clear the difference between two bleedings?
Yes.
Okay, no big triad. Very important. Hypotension, congested neck veins, muffled heart, or distant heart sounds. You see here, tension pneumothorax, hypotension, jugular venous distension. This is tension pneumothorax. This is the third difference between them. But the question in the MRCS, it wasn't like this. This is hypotension, but it is not hemothorax. In hemothorax, you will find hypotension, empty or decreased GVP, and decreased breath sounds. Tension pneumothorax will give the same picture except this one, because there is compression on the heart or kinking of the heart as well, so neck veins will be congested. But you have to take care of this one. Absent or normal breath sounds. This is the key to differentiate between it and tension pneumothorax. And this is the key to differentiate between it and hemothorax. Tension pneumothorax and hemothorax. Clear all scenarios?
Yes.
I think we know now the difference between the three. Okay. Next question.
Number 97, a 20-year-old woman presents acutely with abdominal pain. Imaging reveals a right ovarian cystic lesion which is excised. Histological examination shows a cyst lined by keratinized stratified squamous epithelium. Area of fat, muscle, thyroid, and neural tissues are seen in the wall. What is the appropriate pathological designation for this lesion? It is
Okay, repeated. This is repeated from the last record. Yeah, teratoma. Different tissue pattern. So this is teratoma. Okay, next question.
99, 98.
98. Yeah.
97. I just wrote. 98, 21-year-old man comes into emergency department with a severe headache and neck stiffness of recent onset. You suspect acute meningitis, decided immediately to treat with antibiotic, perform a lumbar puncture after your third attempt to obtain CSF. You notice that fluid obtained is stained red. However, during the collection CSF into 3 containers, it is noted that final bottle is now cleared of any blood. Which anatomical structure is most likely to be responsible for this bleeding? The question they want to ask, injury to any structure, not CSF, lumbar puncture is not the main thing. There is injury to interspinal artery, epidural artery, subarachnoid vein, veins within erector spinae muscle, vertebral venous plexus. Vertebral venous plexus. Source of bleeding.
Vertebral venous plexus. Source of bleeding in lumbar puncture is the anterior, is the internal vertebral venous plexus, and mainly the internal one. Okay, the vertebral venous plexus are 4 plexuses, 2 internal and 2 external, 2 anterior and 2 posterior. So you have anterior, external anterior, and internal anterior, and you have this in part B, and you have posterior external and posterior internal. The internal venous plexus around the dura is the source of bleeding during lumbar puncture. Vertebral venous plexus. Okay.
Anterior external, posterior external. Again, yeah, so
Again?
the same. أيوة, again.
Okay. Okay. In part B, during the study in part B, you have during the study you have the vertebra. Okay. We'll take cut in the vertebra. Venous plexus. You have external here, and this is anterior, and you have external here, and this is posterior. Inside you have anterior and you have posterior. Actually, they all make around the column, but they named like this: anterior, anterior internal, and anterior external, and posterior internal and posterior external. During lumbar puncture, this is the source of bleeding. Clear?
Yes, please.
And I think, I think it's here. Oh, anterior internal and anterior external. Posterior internal, posterior external. Okay.
Number 99.
Okay.
A 25-year-old woman presented in the surgical clinic with a 3-month-old history of diarrhea. On examination, she is found to have a smooth 2-centimeter swelling in the front of her neck. Her sister has a similar swelling, which was operated on 2 years back. The swelling moves on swallowing, and the patient is clinically euthyroid. FNSS cytology of the swelling shows amyloid stroma, and FNSS shows amyloid stroma, serum calcitonin level elevated. Which of the following is most likely diagnosis? There is family history, there is calcitonin level, and I think it's due to medullary thyroid carcinoma.
It's very simple. Medullary thyroid cancer, high calcitonin, and the pathology is
the only
amyloid stroma.
We see the calcitonin level is medullary thyroid carcinoma.
Yes, calcitonin level high, so it is medullary thyroid cancer. medullary thyroid cancer, it have some sort of family history as well. Okay. Next question.
100. A 74-year-old man with non-prostatic hyperplasia presents to the emergency department with acute urinary obstruction. 30 minutes after urinary catheterization, he collapses with a blood pressure of 74/34 millimeter of mercury, heart rate 128 beats per minute. What is the most likely diagnosis? After urinary catheterization, 30 minutes after urinary catheterization, he collapses with a
Not 30
low
minutes.
blood pressure.
Not 30 minutes. Sometimes at the same time.
Okay.
This is what type?
But
what
after
what type?
urinary catheterization, urinary catheter is made of latex, and
Okay. This is
it's
latex. What type of
allergy.
type of hypersensitivity reaction?
Immediate.
Sorry.
Type 1.
Type 1
Type
hypersensitivity
one.
reaction.
Type 1 immediate.
Type 1 anaphylactic.
Anaphylactic.
Type 1 anaphylactic hypersensitivity reaction. What is the type of IG immunoglobulin?
IgE.
IgE.
IgE, egg T, as we said. Okay, another scenario we said about that a nurse developed skin rash and allergy to the gloves. What type of allergy, hypersensitivity reaction?
Contact dermatitis for hypersensitivity type 4.
Contact dermatitis type. This is the most common allergic reaction you will face about latex. Catheter, it will be the patient will faint and will have penile edema at once, and this is type 1 IgE, and the other one is nurse developed the allergy, means developed that she has long time wearing gloves, and this is type of delayed hypersensitivity reaction due to contact dermatitis, and the type of reaction here.
Deleted.
Type
Sorry?
4.
Type 4 mediated by
T cells.
T cell reaction.
Just
T cell
cellular
reaction.
immunity due to cellular.
T cell reaction. Okay, thank you, Dr. Khadija. Who is next, Dr. Amina? Are you ready?
Yes, I'm ready.
Thank you, Dr. Khadija. Okay. Yeah, continue.
A 70-year-old man has a basal cell carcinoma resected from his left temple. What is the most important prognostic indicator? Clinical, pathological type, completeness of excision, intensity of the lymphocytic infiltrate, lymphovascular space invasion, mitotic index in the tumor island. It's completeness of the excision.
Okay, most important prognostic factor post-operative is completeness of the excision of the basal cell carcinoma. Okay.
If it was melanoma, it would be the Breslow's thickness, right?
Breslow's, so we will have this question. Most prognostic factor in melanoma is Breslow's thickness. In basal cell carcinoma, it's completeness of excision. Okay, we will have this question. Next question.
A 68-year-old man has undergone emergency surgery to repair a leaking aortic abdominal aneurysm. He underwent transfusion with 6 units of packed red cells. Blood tests were performed 2 hours post-operatively. Hemoglobin was 10, white blood cell is 12.3, platelets is 40, and the APTT is 36, INR is 2.2, fibrinogen is 1.5, fibrin degradation product is 25. What will these results be consistent with? Since the FDP, the fibrin degradation is high, fibrinogen is high, INR and APTT is all high, that would indicate DIC. A.
Platelets? You didn't comment about platelets?
Oh yeah, the platelets is low, 40.
Platelets are low. Okay. So platelets, low platelets, or there is consumption of clotting factor, consumption of platelet, and increase in fibrinogen degraded products, high INR, high APTT, and the patient history of receiving 6 units of packed RBCs, so massive blood transfusion. So this patient will can go for DIC, and this is a picture of DIC. In the exam, will give you a table with hemoglobin, white blood cell, platelet, APTT, INR, fibrinogen, and fibrinogen degraded product. By the way, you will find no question in the exam, other question in the exam, if you have no other questions in during your study, they will give you this data. Okay, mostly when you give you this data, he is asking about the IC. Clear?
Yes.
Okay. He mentioned this in one question only, when he want to tell you I have this problem, but in normal question he didn't mention, who is not asking about the IC. So once you found this question mostly will be the IC, because it will be never mentioned again in any question. Okay, next question. This is repeated also.
A 46-year-old woman is seen in the pre-admission clinic. She had a myocardial infarction 2 years ago. On examination, she's in atrial fibrillation, and a recent echocardiogram shows that she had a dilated left ventricle. She's on warfarin, and her INR is 6.1. That is very high. Warfarin inhibits which of the following? It inhibits prothrombin factor 2.
Okay. Warfarin acts on extrinsic or intrinsic factor?
Extrinsic.
Extrinsic factor. Okay, and monitored by?
INR or PT.
The same, it's INR or PT. INR or PT, extrinsic factor, heparin intrinsic factor, and monitored by PTT or APTT. This is reversed by protamine sulfate, and as we said here, reversal will be with plasma complex concentrate followed by prothrombin complex concentrate, fresh frozen plasma, and lastly vitamin K, but not in emergency situation. Okay, next question.
A 29-year-old pregnant woman is having uncontrolled labor pains. She has an epidural for pain relief. Which of the following is true? An epidural puncture should only be performed up below the L1 level to avoid damage to the spinal cord. An epidural puncture should only be performed below the L4 level to avoid spinal cord. The epidural space, also known as the extradural space, contains numerous nerve roots and venous plexus. That is true, because epidural puncture can be performed anywhere. So A and B is false. The ligamentum flavum is rarely pierced. No, it's always pierced. The supraspinous and interspinous ligament are rarely pierced. No, they're always pierced.
Okay, so we said the right one is
C.
Okay, the right answer is C, because the epidural space contains numerous nerves, nerve root, and venous plexus, which is the internal venous plexus, which have bleeding during your lumbar puncture. Okay, next question.
A 28-year-old motorcyclist presents to the emergency department after being involved in a road traffic accident. He has a closed, isolated injury to his right leg. Radiographs show a segmental fracture of the tibia and fibula. Intramedullary nail of the tibia is undertaken. 6 hours following the operation, he complains of severe calf pain, which does not respond to analgesic. Movement of the toes severely increases the pain. What is the most likely cause of this pain? This is compartment syndrome. So it's raised intercompartmental pressure, because it's pain that does not respond to analgesia.
Okay, patient take intramedullary nailing, tibia, and 6 hours later after the operation, patient has severe calf pain, which doesn't respond to normal analgesic. Very common complaint that pain not responding to normal analgesic. Movement of these toes severely increase the pain. So this picture off. So this picture is off. Raised intercompartment or compartment syndrome. Okay.
Yeah.
Next question.
A 65-year-old woman with metastatic breast cancer is admitted to the hospital confused and acutely unwell with nausea and vomiting. Her vital signs are within normal limits. What abnormality is most likely to contribute for her clinical condition? This is a metastatic breast cancer, so it is due to hypercalcemia, A.
Okay, hypercalcemia, metastatic breast cancer. This is repeated from, I think, last recall. Next question.
During recovery from varicose vein surgery, 35-year-old woman complains of weakness of dorsiflexion of the ankle. Physical examination reveals absent sensation of over dorsum of the foot, which of the following nerves is most likely injured? Dorsiflexion of the ankle and absent sensation over dorsum of the foot. This is due to common peroneal nerve injury because it includes both. Yeah.
Both nerves.
Both
okay.
nerves.
So both nerves. So I'll go for. So here he tells us deep peroneal, superficial peroneal, but I have symptoms from both nerves. So this is will be common peroneal nerve. And next question.
A 78-year-old woman with chronic obstructive pulmonary disease becomes confused after a right hemicolectomy. She's on 30% oxygen and her blood gas analysis shows the carbon dioxide is high, that is acidotic, and the oxygen is okay. No, the oxygen is low. She has high carbon dioxide and low oxygen, so this is type 2 respiratory failure.
Type 2 respiratory failure. Type 1 is?
Type 1 is
hypoxia.
Only hypoxemia. Only one parameter.
Type 1,
Without
only one
hypocapnia.
parameters, so hypoxia. Type 2 is two factors. Respiratory, type 2 respiratory failure. Exactly. Both of them under the title of respiratory acidosis. Both of them under the title of respiratory acidosis. Some questions of ABG. In some questions of ABG, you find picture of respiratory failure, type 1 or type 2, and then go to the question. You search for respiratory acidosis and you can't find it, you will find respiratory failure type 1 or type 2. So both of these, some questions, both of these equal respiratory acidosis. Sometimes he give me ABG and this, oh yes, this is respiratory acidosis. Then I go in the options, I don't find any respiratory acidosis, but for sure I'll find one of these. So in respiratory acidosis, I have to decide it is type 1 or type 2 respiratory failure. Okay. We have one example like this in MRCS. Next question.
A 19-year-old man fell down a flight of stairs. On presentation to the emergency department, his Glasgow coma scale was 14 out of 15 with no focal neurological signs. An hour later, he vomited and his Glasgow coma deteriorated to 10. He developed fixed and dilated left pupil. Which of the following accounts for the pupillary signs? This is due to compression of the oculomotor nerve parasympathetic fibers because it carries the parasympathetic, which is responsible for the constriction of pupil. And since that is and since the oculomotor nerve is compressed, so there is no parasympathetic, and thus the eye will be dilated. Only sympathetic will be working.
Okay. This picture is very nice. I always like it to explain about this one. Intrinsic eye muscles. Okay, good. Yeah. Clear? Clear this picture. Intrinsic eye muscles. I have here parasympathetic and I have here sympathetic. Okay. Parasympathetic, increase tone of parasympathetic will cause pupillary constriction. Increase sympathetic tone will cause pupillary dilatation. Okay. Someone answer me. Okay. Pupillary constriction is a parasympathetic. Okay. Because applies a constrictor pupillary muscle. Sympathetic will cause pupillary dilatation because it supplies the pupillary radiator dilator muscle, the pupillary dilator muscle, or the dilator pupillary muscle. So sympathetic makes this contract, so it makes dilatation. Parasympathetic will this contract, so it will make pupillary constriction. What happens in this question? Because it comes with two scenarios. All of this to tell you that this question comes with two scenarios. In presentation to the Glasgow scale, 14 out of 15, no focal neurological, GCS related to 10, reduced to 10, and then developed fixed dilated left pupil, which of the following accounts for pupillary sign. You can find the answer by two pictures. Compression of the oculomotor nerve, parasympathetic fibers. Anyone know the other thing?
So EDH.
Unimposed sympathetic stimulation. Sorry. Stimulation. Unopposed sympathetic stimulation. You'll find it by two. Either he will tell you increase the parasympathetic tone, or he will tell you compression of the oculomotor nerve, so the parasympathetic will not acting. So the eye remain in this position because of equalization or equal power of both sympathetic and parasympathetic. When you abolish one of them, there will be unopposed action by the other supply, so this will be sometimes you'll find this compression of the oculomotor nerve parasympathetic, and sometimes you'll find it unopposed sympathetic stimulation. Clear?
Yes, yes.
Yes, clear.
Okay.
I didn't understand about unopposed sympathetic stimulation. Can you repeat it again?
You want to repeat again?
Just the unopposed sympathetic stimulation from that part.
Okay. This is the normal eye. And I have here like this. Okay. I have power from here and power from here. Both of them are the same. Parasympathetic and here sympathetic. Both of them make the eye like this. If one of them is abolished, the other one will be more effective Yes?
Yes.
So there will be unopposed action of sympathetic. Yani, even he will tell you abolish or compression of the parasympathetic, or he won't tell you there is abolition or abolish of the sympathetic parasympathetic supply, or he will tell you there is unopposition of the sympathetic overactivity. So he will tell you unopposed sympathetic stimulation. Sympathetic stimulation has nothing to oppose it, or he tell you there is compression of the parasympathetic. Both are the same mnemonic of the same answer. Compression of the oculomotor. This is very common in the exam, but once it came before unopposed sympathetic stimulation. Unopposed sympathetic stimulation. It came once before. Clear?
Clear.
Okay. Next question.
A 32-year-old mountain biker presents to the outpatient clinic. He fell awkwardly with excessive lateral flexion of his neck to the left side. He describes some paresthesia over his right shoulder and lateral arm, which appears to have been improved over the past hour. What is the most likely injury suggested by this history? Since it's just paresthesia, it's going to be neopraxia of the C5 nerve roots. And it's like over the right shoulder and lateral arm, and that is the C5 area. So it's C, neuropraxia of the C5 nerve root.
Okay. So here is what happened to the patient. Improvement after improving over the past hour. Okay. So what type of injury for the nerve here? Hello?
Yeah, hello. It's neuropraxia.
Yes, what neuropraxia, okay? So as I read this question, what I say, because this is common injuries you like in the exam. There is improving within 1 hour. So what happened? Just like put your hand like Saturday night, or you forget your hand, put your hand on a chair, on an armchair for a long time. Okay, what will happen? Compression of the nerve and start to improving. So this is neuropraxia. So when I read like this, I will exclude all of this except this, and then go back. What is the pathology? Over his right shoulder and lateral arm. What is lateral arm? C5, sometimes C6. And lateral arm, sorry, مش forearm, so it is C5 and shoulder, the side of C5, but T1 will be medial side of the arm and forearm. So I'll choose neuropraxia at the C5 root. Okay. Next question.
A 62-year-old woman presents with a firm irregular mass in the upper outer quadrant of the right breast. This appears malignant on mammography, and fine needle aspiration cytology is reported as C5. Which is the first lymph node to which the tumor is most likely to metastasize? The first lymph node is the sentinel lymph node, D.
Okay, sentinel lymph node is the first lymph node to which is a tumor metastasized. Thank you, Dr. Amina. So, Dr. VJ,
you're welcome.
Are you ready? Yellow, next 10 questions so fast in 5 minutes.
Yes, I am. I'll start from 112.
112, yeah.
A 50-year-old woman presents with a history of fecal incontinence over the past few years. She had a prolonged and difficult first stage of labor 20 years previously. Clinical examination reveals a relatively lax anal sphincter, Which nerve is likely to have been damaged in labor? So it's a pudendal. So anytime, yeah, this question is straightforward. Anytime where you have post-pregnancy incontinence, it's always pudendal nerve.
Yeah, post-delivery, special vaginal delivery or episiotomy, and you have any weakness in the anal sphincter or in the urethral sphincter, both of them are supplied by the pudendal nerve repeated from yesterday. Next question, our famous question.
Yeah, a 26-year-old man presents to the emergency department with extensive bleeding from his arm after sustaining glass injury. On examination, there is a 7-centimeter transverse laceration across the anterior aspect of his elbow. On exploring the cubital fossa, you would expect the brachial artery to be. Okay. So I remember AVN, so artery, vein, nerve. So the nerve is the most medial. So the artery should be medial to the nerve. Sorry, lateral to the nerve. So that's gonna be C. Yeah.
The artery.
So, AVN, artery, vein, nerve. This is the order.
We have no question about the vein in MRCS.
Yeah,
if you
but,
have it in USML, we don't have. Yeah.
Yeah, but AVN is the order in the whole body. Anywhere in the body, AVN is the order from lateral to medial. Yeah. But only in the ribs, it becomes reverse.
Okay. Can you just note about this question because it's very famous?
Yeah.
You have the artery, and you have many questions, and this is a cubital fossa. This is a cubital fossa, and you have two nerves. Okay. And you have two nerves. The most common nerve you asked about is the median nerve. The median nerve is medial to the artery. But sometimes he asks you about the full course, as happened in my exam and many exams. What is the course of the relation of the median nerve to the artery, to the brachial artery? It is lateral, anterior, medial. Lateral, anterior, medial. Okay. So in the cubital fossa, in the cubital fossa, he always asks you during exploration of the cubital fossa, what is the relation of the nerve to the artery or the artery to the nerve? You have to concentrate. The nerve is medial to the artery. If he asks it here, like here, the relation is the artery. The artery is lateral to the nerve. I'm talking about median nerve.
Median nerve. Yeah.
Okay.
Now, you're saying the median nerve is lateral and then it becomes medial, right?
Lamb.
So it crosses over?
Lamb, lateral, anterior, medial. Lamb, lateral, anterior. So this is the median nerve to the artery, lateral, anterior nerve, medial. The other one he asked about is the ulnar nerve.
Biceps tendon, I guess.
Ulnar nerve. But he don't ask about ulnar nerves in the cubital fossa because it passed behind the medial malleolus. He always asks about the ulnar and the arm.
Also the biceps tendon. They also ask, I saw a question on biceps tendon.
This is the ulnar. This is the ulnar. Okay. Always ask about these nerves. Ulnar nerve is always medial to the artery, whatever he asked you where, but always ask you on the arm because he didn't ask you on the cubital fossa. The median nerve has lamb position, lateral, anterior, medial. In the exam, you have two questions. One question asking related to nerve to the artery, and the other one artery to the nerve. And this is the three questions about the relation of vessels in the arm. Okay, this is the commonest question, and you will have one or two in the exam from this. You will have 1 or 2 questions from this question in the exam. Trust in me, and you remember me in the exam.
Sir, could you please repeat the one with the ulnar nerve?
Ulnar nerve always medial. Always medial. This is the ulnar nerve.
Okay, sir.
Always medial for arm, but he didn't ask you in the forearm because it go behind in the cubital fossa, because it go behind the medial epicondyle.
Yes, sir.
So he only asked about the ulnar in the
yes, sir.
in the arm. Relation of the, and always ask about the median in the cubital fossa, and sometimes ask about the full course. But he never asked about it in the arm alone, because in upper part of the arm it will be lateral, and the lower part of the arm it will be lower. So he even only asked about the full course, or he asked about the cubital fossa, about related to the median nerve.
Okay, sir. Thank you.
In case of ulnar nerve, there are maybe 2 questions. That is behind the medial epicondyle.
No. It doesn't come behind the medial condyle. Is not come. Not come. I'm telling you, he will not ask you in the cubital fossa about the ulnar nerve, because it is always hidden behind the. You can't be seen during exploration of the cubital fossa.
And
in the cubital fossa, he asked
wrist.
But in the arm, it will be up. In the wrist, the nerve is always outside.
Outside.
The nerve is always outside. Okay. Okay. Nice question. Nice question.
Thank you, sir.
Okay. It will come in. This is the. Okay. This is one artery. And this is another artery. And this is the hand. Okay, and because this is the fingers, and you have the nerve. Okay, this is, and this is. Okay. This is ulnar, and this is radial. Okay. This is the ulnar artery, and the ulnar nerve is medial. Yes, outside. The nerve is strong fibers. The nerve is strong fibers. So it always protects the artery inside, like a man and his woman and his wife. He outside to have any trauma outside. On the other side, the radial, also outside, and the vessel is inside. So sometimes he asks you, but the most common is the relation between the radial artery to the radial nerve, and the most common the relation between the ulnar nerve and the ulnar artery. He can give you 2 options. The most common, he will tell you the ulnar nerve is ulnar to the ulnar artery. Okay, ulnar means medial. Clear? Or get confused?
No.
The nerve is always ulnar. The nerve is ulnar to the ulnar artery, and the nerve is radial, which equal lateral to the radial artery. Not to forget it. Ulnar nerve is ulnar to the ulnar artery, and the radial nerve
Ulnar
is radial to the radial.
They means lateral. Ulnar
No. Ulnar nerve. I'm talking about the nerve.
Yes.
Is always ulnar to the ulnar artery, means medial to the ulnar artery. The radial nerve is always radial to the radial artery, means lateral. Ulnar nerve, ulnar to the ulnar artery. Radial nerve is radial to the radial artery. Clear? This means that it is medial to it, and this means it's lateral to it. And as I told you, they always keep the vessels inside and the nerves outside. Whatever he asks you, you can know by thinking it is medial or lateral, it is ulnar or radial, but this is very common in the exam. He tell you what is the relation of the radial nerve, the ulnar nerve to the ulnar artery. He will tell you ulnar to the ulnar artery, or ulnar nerve is ulnar to the ulnar artery, or medial to the ulnar artery, whatever he told you, he tell you, okay? Next question.
53-year-old man complains of crushing chest pain at rest. He has chronic hypertension. He's a heavy smoker. Pulse rate is 138 and blood pressure is 140/90. What is the principal cause underlying his reduced coronary artery blood flow? Okay. So his heart rate is very high. So because his heart rate is high, his heart will spend less time in diastolic filling, and that's the phase when the coronaries are perfused. So it's option C.
Yes, decrease the diastolic interval because the coronary arteries are filled during diastole. Coronary arteries are filled during diastole. It gets its blood supply during diastole. Okay. Nice. Decrease the diastolic interval. Everyone understand this one?
Yes.
Okay. Next question.
58-year-old woman, a known patient with thoracic right-sided meningioma, presents with features suggestive of Brown-Séquard syndrome. Okay, the clinical findings will include which of the following? Okay, Brown-Séquard. So Brown-Séquard is half of spinal cord, right? Hemisection.
Yes.
So all the tracts are basically involved. So you'll have ipsilateral loss of vibration and proprioception, and contralateral loss of pain and temperature sensation, right?
Okay. Ipsilateral motor, vibration and proprioception, and contralateral pain.
So yeah,
okay.
So since it's right-sided, you have right-sided weakness, yeah, proprioception, and left-sided windbreak. But does it happen like meningioma is in the brain, right? Usually, so it happens even in spinal cord.
Yes, it can happen. Why not happen? Yeah.
Okay, I mean, I never saw.
No. Meningioma can happen any place. Meningioma can happen anywhere. It is very rare, yes, but it can happen many places. Sometimes he tell you stabbed on the back, and he has hemisection on the hemisection of the spinal cord. By the way, very important, Shabab, Brown-Séquard syndrome. You will have a question in the exam. This question will come in the exam. This question will come in the exam. Sometimes he tell you right or left, and sometimes he'll bring for you ipsilateral or contralateral. Sometimes he tell you the patient he told you he has right-sided Brown-Séquard, right-sided compression. So you have to go for the left and right and to be confused in the exam. it is easy. Actually, it is easy. It is came if this came ipsilateral or contralateral, because this what will depend on our ipsilateral motor, proprioception and vibration, and contralateral pain and temperature. Contralateral pain and temperature. Okay. Sometimes he tell you left or right, so you have to. Ipsilateral means if he told you I have a right pathology, so I'll have right motor, proprioception and vibration, and I'll have left pain and temperature sensory. Okay, so ipsilateral X, you'll go direct with the pathology you have. How to solve a question like this in the exam? A question like this in the exam, I go in my mind direct and see. This is right-sided meningioma, compression on the right side. So I will have right-sided motor lesion. Think first about the motor, because this is the most important two things. You can finish the question by this. Motor and sensory. Sensory, which means pain and temperature. Pain and temperature. So you'll have ipsilateral motor and the contralateral loss of pain and temperature. Go for this direct. This is right. Ipsilateral equals right. So left-sided weakness, completely wrong from the start. You're not complete reading. Right-sided weakness, yes. Right-sided weakness, yes. Right-sided weakness, yes. Left-sided weakness, completely. So I excluded from the first sentence, I excluded A2. Then go to the, I need the sensation. I need the sensation. Okay. The same proprioception and vibration will be at the same side. So I go here. Right-sided proprioception. And okay, yes, this is right. Continue. Right-sided, yes. Left-sided. So I included the third one. Then I have this. Go for the sensation. I found here left contralateral sensation. So this is right, and both of them for right. For me in the exam, what I did in the exam, I searched about the weakness, and I searched about the sensation, which is pain and temperature or light. By the way, pain and temperature or light sensation, or crude touch. Sometimes they make it light sensation or fine touch. Okay, this is the same. In the exam, mostly will give you this or pain and temperature. Pain and temperature. Or sometimes the tempric, which is pain and temperature, if he didn't bring temperature. So I go that always in my exam, when I'm solving, I go for search for weakness and search for pain and temperature. Should be ipsilateral weakness and contralateral loss of sensation. And then if I have more data to check, I have to check it if I found two things. But for me, if I'm going in the exam, I'll choose this and search for sensation. Right side is sensation, wrong, right, wrong, left here, but already I excluded this from the start. So I will go direct for this. This question will take 30 seconds in solving. Clear?
Yes.
Okay. Next question.
70-year-old woman presents with a fractured left humerus. X-ray shows an osteolytic lesion at the site of the fracture. Histological examination of a sample taken at the time of internal fixation shows a metastatic carcinoma. What is the most likely primary site? So it's osteolytic, right?
Mm-hmm.
So, okay. Yeah. Okay, it could have been colon too. I mean, from my knowledge, what I know, both breast and colon can have both osteolytic and osteoblastic lesions. Endometrium, ovary, stomach, I don't know. Yeah, but one thing I know is prostrate. Prostrate is osteo, what do you call
Sclerotic.
osteo,
Osteosclerotic.
osteoglytic,
Sclerotic.
Okay.
and then plasma cell leukemia
Okay.
is osteolytic.
Don't confuse yourself. Don't confuse yourself. In MRCS, all METs are osteolytic, except for prostate in men. Okay, this is an MRCS. You'll find no question about osteosclerotic or osteoplastic METs except for the prostate. I don't want you to know any other one. This is the first thing to know. This question not asking about osteolytic or osteopathic. This question asking about the most common MET in female old age. The most common type of MET, or the order of METs you have to think about. Okay, the order of METs you have to think about. The most common METs are breast, lung, and then prostate. So here's breast by 50 to 85%, followed by the lung by 30 to 50%. In male, it will be 50 to 70%, mainly from prostate, but it will be osteosclerotic or osteoplastic. Clear? So the idea of this question, he wants to tell you what is the most common bone METs in female old age. Okay.
And also, usually bone METs are by usually 5 sides, right? Thyroid, lung, breast, renal, and prostate. Into that also only breast is one that is included in the answers.
Yeah, but breast is the most common. You want you to know this. Okay. And the most common site any tumor metastasis to is the bone. If you want to ask you, any patient has any cancer, most common site to metastasis to mostly will be bone. You know, BL, bone, liver, brain, lungs. So the bone is, according to our MRCS study, and the bone is the most common site for metastasis. I'm not talking about individual variations or some tumors variation. Some go to the liver first, some go to the lung first, some to, but in the general, any metastasis for any tumor in the body, primary mostly the bone has the highest percent of metastasis, followed by the liver, followed by the brain, followed by the lung. So this question is asking about what is the most common site you have to suspect in your mind. If I found bone metastasis in female old age, first thing you have to look to the breast. Next question.
74-year-old man presents with the pulsatile swelling in his abdomen. The principal abnormality within the wall of the arterial aneurysm is loss of. So 74, so that's elderly. So nothing, both the collagen options are wrong. And also the elastin options, wait a minute. Okay, so aneurysm is usually something is wrong between the intima and the externa, right? So medial elastin, yeah.
Okay, medial elastin. What is the principal abnormality? Abnormality, okay. Atherosclerosis, this man has with pulsatile swelling in the abdomen. So this is
Cystic. So cystic medial degeneration, that's classic
cystic
age-related degeneration. It's the
medial,
most common pathology
cystic medial
for age-related aneurysm,
degeneration.
abdominal aortic aneurysm.
Elastin, this is elastin pathology.
Yeah.
Elastin pathology, cystic medial degeneration, elastin pathology. Another question come, what is the main cause or most common cause of abdominal aortic aneurysm? You will find atherosclerosis. Don't mix between the pathology, most common pathology, and most common etiology. Okay, an old man, most common etiology is atherosclerosis. Most common pathology is medial cystic degeneration of the elastin fibers. Clear? This is the two questions you will have about abdominal aortic aneurysm. Okay.
So what is the most common etiology?
Atherosclerosis.
Okay, sir. Thank you.
In old age, atherosclerotic. And if it is family history, it will be
Marfan's
syndrome. If gives you in the scenario.
Marfan's presents very, very early, right? 74 is
Yes.
too late for Marfan's.
You will find very early, very early. But if he's tried to mention some family history about abdominal aortic aneurysm or aortic dissection, or patient died in young age, tall patient, he will tell you female, tall patient, and her father was tall and died from aortic dissection in 45 years or 50 years, so in middle age, and he died from an aortic problem. And he gave you one of the rare questions in the exam that he will tell you female tall patient. Tall patient, female, tall in your MRCS exam, trick equals Marfan syndrome. Search when you find tall patient in your question in the exam, search in the answer about two words, Marfan or aortic dissection. We will see this question during our recall. Yeah. Next question, please.
Sorry, sir. You said if the keyword tall comes, then it's like either it's Marfan or?
If you find tall, mostly female patient,
yeah,
and in any question, search. Most, I'm saying most, maybe 90% or more, 95%. Search and answer about Marfan syndrome or aortic dissection.
Okay, sir. Thank you.
This is some tricks in the exam. And it is not scientific tricks, but it is very common tricks. Like I tell you, when you find in the question fibrin degrading products, you have no topic in MRCS have this word except in the IC. Okay. At least in our study. Okay, next question, please.
A 24-year-old woman presents with a swelling in the thyroid gland. She also has enlarged lymph nodes in the left anterior triangle of the neck. Which of the following is the most likely diagnosis? So, yeah, so they just gave us that metastasis happened. So I don't know actually the answer for this.
Okay. We said before what you will have, what is the keyword for everyone. We have follicular we have papillary, we have anaplastic, we have medullary cancer. What is the keyword for follicular?
Bone metastasis.
Okay, follicular, R. So it metastasized mainly early by blood.
Metagenous blood.
He will tell you pulsating,
Mass on the forehead.
bony or a skull
Skull. Yeah.
mass, and swelling on the midline of the neck or thyroid swelling. So this is follicular. Papillary, sometimes papillary is Y, yes. So it is spread by yellow,
Lymphatics.
by lymph. So it will have lymph node. Okay, so it will spread by lymph node. So this will be presented by cervical lymph node. Sometimes the cervical lymph node appear and still the tumor in the gland not appear. So sometimes he don't mention for you, you have a thyroid swelling, but he tell you there is a cervical lymph node, and during his pathology, you'll find thyroid. He describe for you thyroid pathology, papillary projection and the glands or thyroid gland and something like this. So this is papillary thyroid tumor, okay? And this is named, sometimes we name it cervical thyroid. The myths, because it is rapidly spread by lymph, sometimes makes cervical lymph node, which will be palpable before the main tumor will be visible. Okay, so this will be cervical. So cervical lymph node and pathology, as the first question we have in Fawzia sheet 1, you will go for papillary. Anaplastic, this will give you, okay, wait.
So I cannot see the questions. I don't know why. Is it only for me?
What?
I cannot see this screen that you have shared.
You can't see the screen?
I don't
Anyone
know whether
else
it's
can see
only
the
for
screen?
me or not. I cannot see the screen.
It's clear.
Anyone
Can
has
we
any
see the
problem with
screen?
the screen? Because
No.
by the way, I'm opening it from two sources, so I confirm that my voice and screen is good. For me, on my iPad and my laptop, the screen is clear. Anyone have this problem?
Oh, now it's now I
It's
can
clear.
see the screen as well.
Okay, let's continue.
Now I
Anaplastic.
can see the screen.
Okay, anaplastic has a different story. He will tell you 70 years old patient, mostly female, with swelling or mass midline of the neck, and attach it to the skin and nearby structure and to the muscle. Fix it to the skin and muscles, and rapidly growing.
So
Rapidly.
anaplastic can have symptoms like neck stiffness, right?
No, why neck stiffness? Just frozen neck.
Frozen neck.
Frozen neck. It is a mass rapidly growing in a short time and attached to the skin and nearby structure. This will go for anaplastic.
So they might also say hoarseness because the recurrent laryngeal nerve.
No. He will tell you as I told you only. I will tell you as I told you only. He will tell you rapidly growing mass, attach it to the skin and nearby structure or on the muscle and fix it to the midline of the neck. In around 70 years. This patient maybe will be around 40 patient, 45, 50, something like this. Sometimes in papillary young age as well, 30 years. This anaplastic. Medullary spread mainly by lymph, okay? But always medullary, he will tell you, as we said the last question, patient have high calcium, high calcitonin, and part of main syndrome, hypertension, pheochromocytoma, high parathyroid hormone, high calcium as well, and so on. So it will be also
No sound.
No sound.
sorry.
Yes.
He will tell you the patient, mostly he will tell you medullary, part of main syndrome, and tell you the patient has hypertension. Why? Pheochromocytoma. The patient has high calcium. Why? This patient عنده parathyroid adenoma or hyperplasia. The patient has what else about medullary? Yani almost this. Sometimes the patient have macrocephaly, or the patient has enlarged, or the patient developed tightness, or in a big hand, or hands becomes enlarged, and he has tight clothes and tight ring and something like the picture of growth hormone. Okay, enlargement of facial facial impressions, and the hand started to be big, his foot started to be big, and his shoes started to be tight. He asking about pituitary adenoma, and so on. This is related to medullary, and the others we said the difference between. Clear?
Yes.
Okay, next question. Dr. Vijay, your mic is off.
No, it's on. Okay. So a 20-year-old man with a severe head injury is being ventilated using positive pressure. Which of the following is a physiological consequence of this? Head injury. Okay.
No, he is asking about the positive pressure. When you give a patient a positive pressure ventilation, what the physiological effect will happen due to this positive pressure?
So positive pressure, that means the lungs will start to hold more blood, right? So there will be less blood returning from the lungs.
Increase
So
the intrathoracic pressure.
Yeah.
Increase will
So
increase the
left
intrathoracic
heart,
pressure.
so there will be a decreased preload in the left heart.
Okay, decrease the venous return and decrease the preload.
Yeah.
Okay.
Yeah.
compression will زيد. Positive pressure ventilation will increase the intrathoracic pressure, so will decrease the venous return to the heart, so will decrease the cardiac preload. Decrease the cardiac preload. Next question.
A 70-year-old man presents with a 1-week history of epigastric pain and profuse vomiting. The most likely consequence is epigastric pain and profuse vomiting. Okay. Yeah, it's gonna be hypokalemic alkalosis because the patient will lose both hydrogen.
Vomiting. What is the metabolic disturbance will happen
Yes.
for
So
a patient with
the acid in the stomach, the hydrogen ion will be lost, and because of the hydrogen ion loss, there will be alkalosis. And to replenish the hydrogen ion in the stomach, the hydrogen potassium pump in the stomach will exchange the potassium for the hydrogen. So there will be a loss of potassium in the blood. So the potassium in the blood will be decreased.
Okay.
That's why you have hypokalemic alkalosis.
Okay. Patient with profuse vomiting will have hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. Hypokalemic, keep this in your mind like your name. Patient with profuse vomiting, hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. Mechanism, long mechanism. You need it in part B about hypovolemia and loss of sodium and the stimulation of renin-angiotensin aldosterone system, so we preserve sodium and lose potassium, so the patient will have hypocalcemia, and also during loss of potassium, preserve sodium, so you are preserving positive anions. So to preserve positive anion, you have also to preserve potassium. You will exchange potassium for hydrogen, so the patient will lose hydrogen ion in urine, so the urine will be acidic. So the patient, in spite he has alkalosis and also he has paradoxical aciduria. All these details not required from you in part A. What required for you in part A? Sometimes this sentence come as a completed choice.
How does paradoxical aciduria happen? I mean, the patient is already losing hydrogen ions, right? Why would aciduria happen? The kidneys will try to retain as much hydrogen ions as possible.
I'll send you the pathophysiology all on the Telegram after we finish on our break. Okay. Yeah, continue.
A 22-year-old.
But you have to know this. You have not to forget hypochloremic, hypokalemic, metabolic acidosis with paradoxical aciduria. Yeah, continue. Last question, please.
22-year-old man arrives in the emergency department with sudden breathlessness due to large pneumothorax. An immediate chest drain is inserted into the 5th left intercostal space, the mid-axillary line. There's a hemorrhage into the draining bottle. Which of the following structures is the most likely cause of this acute hemorrhage? Obviously, intercostal artery.
Intercostal artery.
Between the ribs, there is only one artery. It's intercostal.
Most close. The most close is the artery.
Yeah.
So the main, this question will come in the exam. This question come 100% in every exam. In every exam, 100%, the source of bleeding during intercostal tube. Clear? Okay.
And also
Next question.
the order, it's below the rib, it's vein, artery, and nerve. Yeah, it's
really out of our scope.
Yeah.
I know. Really out of our scope. What will come in your exam? Intercostal chest tube bleeding. What is the source of bleeding? It came about 20 times last 4 or 5 years. He doesn't ask about the organ. If you want to know, okay, you will remember from vein, artery, nerve, but he never. You will be unlucky if it came in next exam. You will be unlucky if it will be because it never came before.
The right
okay,
and
next
left.
question. I'm trying to make you concentrate in the exam targeted revision. Okay, next question.
The right and left pulmonary arteries are derived from which of the following embryological aortic structures? So pulmonary arteries, yeah, 6th. Yeah. So do we need to memorize the whole table?
No, I'm going to tell you what you need to memorize.
Okay.
Okay, last year and 2 exams, he didn't bring the pulmonary artery. Okay, he want to change with words and he bring the ductus arteriosus. Last 2 exams, January and September 2020, he asked about the origin of the ductus arteriosus, which will be the 6th branchial arch. What other branchial arch he bring in the exam? The 2nd branchial arch. What he asked about the facial nerve and asked about the stapes and stapedius, like stapes, stapedius, or stapedial muscle, stapedius sometimes, or stapedial muscle, and ask about the facial nerve. You don't ask about this. Okay. He tell you what is the origin of, or the 2nd pharyngeal arch gives you stapes as a bone, stapedius muscle, and stapedial artery as a muscle. Sometimes says stapedius muscle or stapedial artery. Okay. And ask about the 6th. This is the 2nd. And ask about the 6th. What gives you right and left pulmonary artery? Many exams, and last 2 exams, ductus arteriosus. Clear? Other than this, the table is not needed. What you need to know, you can need the first because it's easy. This is mandibular, mainly mandibular branch. Forget about it. It gives muscles of mastication. Malleolus mandible, this muscles of mastication and mandibular branch. 2nd, also remember that it is responsible facial and responsible for muscles of facial expression. The 2nd branchial arch. So the 2nd, we have facial nerve. If you want to remember, 2nd, 7th. So 2nd and 7th. 2nd, 7th cranial nerve, stapes, stapedius. All is 2nd pharyngeal arch, 7th cranial nerve, stapes, stapedial, muscles of facial expression. The 6th is easy. Pulmonary artery, right or left pulmonary artery, and ductus arteriosus. That's all what you need to know about the pharyngeal arches. What you need to know about the pharyngeal pouch, 3rd and 4th. 3rd give you the inferior parathyroid and thymus. So 3rd, remember 3rd by thymus, and the thymus is low, so we'll take with it the inferior parathyroid. Force will take the superior parathyroid. Superior parathyroid, inferior parathyroid. Clear? What you want to know about the pouch? The pouch gives glands. The arch gives bone, muscle, arteries, and nerves. Bone, muscles, artery, and nerves. Pouch give glands.
Yeah.
You need second and you need seventh. You need second and you need sixth. You need third and you need fourth. Third, fifth, so thymus and inferior, and fourth will give you superior. Clear?
Yeah.
That all what requested from you in pharyngeal arch and pouch in the exam. Sometimes he tell you, okay, during exploration of the parathyroid gland, okay, the inferior parathyroid were not in place. Where you expect to be found? With the thymus in the chest. Okay, this very common question in the exam. During exploration of parathyroid gland, the inferior parathyroid gland were not in place. Where you expect to find? With the thymus in the chest. Retrosternal. Clear?
Yes, clear, sir.
Next question. Continue, please. Dr. Vijay, are you there?
Yeah. In the fetal circulation, the majority of blood passing from the inferior vena cava into the right atrium subsequently passes next into which one of the following? Okay, inferior vena cava.
Some of the cell.
Left atrium, foraminal valve.
Okay, blood come from the inferior vena cava and then come here and don't go to the ventricle, it go direct to the left atrium. Okay, it go direct to the left atrium and then to the aorta. Okay, it not go this pathway and then in this pathway to go to pulmonary, and there is no pulmonary, and then from pulmonary come back and so on. No, let's go from the left atrium to the right, from the right atrium direct to the left atrium. Question about fetal circulation are very few, or very maybe only two questions. Only two questions, and this is one of them, and the another one I think it's in September 2020 we will visit again. Fetal circulation, you have only two questions about. So this is one of them, from right to left atrium during fetal life. Okay, continue, doctor. This is repeated from yesterday.
Yeah, a 36-year-old butcher injures his left index finger with a knife, suffering a deep laceration on the palmar aspect of the middle phalanx. An examination is unable to flex distal interphalangeal joint. Which tendon is likely to have been injured? Okay, so do we need to know all these tendons?
No.
Okay.
Most common question is this question. He wants you to know that the distal phalanx is have the flexor digitorum profunda tendon.
Okay.
Want you to know this. Good.
And so if it is not the distal interphalangeal joint, like if it is a proximal interphalangeal joint, then what
will
tendon?
not ask you. Will not ask about.
Okay.
Will not ask. He only ask about the distal. He only about to ask about the distal. Okay, next question.
39-year-old woman with large expanding ovarian mass that is removed surgically, requiring a lateral pelvic wall clearance, lymph nodes. 4 days post-operatively, she complains of painful spasms in the groin area and remarks that she has an area of numbness in the medial side of her thigh. The most likely explanation, it's obturator.
Obturator nerve.
Later.
This is the area of obturator nerve, medial side of the thigh, and she has some pain, lots of painful spasm in the groin. Okay, and this is, and remark that she has an area of numbness on the medial side of the thigh. This is the obturator nerve area. Obturator nerve area. Okay. This is what, remember that when I told you they will ask you about an ovarian mass, during ovarian mass, you will most commonly that you can injure the obturator. Sometimes he tell you the patient kicks due to contraction of the adductor muscles during the operation. So this will be also obturator nerve. So whatever he tell you, the patient kicks during the operation, during the section, or the patient has some groin pain and some numbness on the medial aspect of the side, so it will be obturator nerve. Thank you, Dr. Vijay. Dr. Munira, are you ready?
Yeah, sure.
Yalla, I want you to run because
Alright.
we still have about 50 questions.
Okay.
Okay.
Question 126. The 70-year-old patient is found to have a sodium of 125 millimoles per liter on examination. There is no signs of hypovolemia. The plasma osmolarity is 280 and urine osmolarity is 1000. Which of the following is best explanation of these findings? Sodium low, both the plasma and urine osmolarity is high. No signs of hypovolemia, so it's probably euvolemic hyponatremia. It's SIDH.
Okay, euvolemic hyponatremia. Plasma osmolarity is normal and urine osmolarity is
Right.
Okay. So this is euvolemic. Urine osmolarity is 1000. So this is called we have an algorithm about the I didn't send it here. Okay. About the hyponatremia. Okay, if you have a hyponatremia in the exam, whatever in the exam, most common question in the exam, 99% patient he ask about syndrome of inappropriate antidiuretic hormone. Okay, he will tell you the patient with hyponatremia and with plasma osmolarity 280, which is normal plasma osmolarity. So normal plasma osmolarity and patient with have low sodium, this will be syndrome for inappropriate antidiuretic hormone secretion. Okay, know this question in physiology. If you want to go for an algorithm for hyponatremia, I can send you the algorithm part that's completely confusing. And the exam most commonly ask about this. Another question, he will tell you if he give you the sodium is normal and the patient have frequent midnight urination, and he will give you the blood sugar test. This patient will have diabetes mellitus or impaired. This patient mostly will have diabetes mellitus. Another thing about he tell you about the osmolarity, and the patient have excessive urination during night and so on. So this will be patient have diabetes mellitus. We will have this question later, but this physiology question highly repeated in the exam, and he want you to know this hyponatremia and normal osmolarity of the plasma. This will be syndrome of inappropriate antidiuretic hormone secretion, SIADA, syndrome SIADA. Next question.
A surgeon is carrying out an elective splenectomy for congenital spherocytosis. Which structure will be divided in order to mobilize the spleen from the posterior abdominal wall? Posteriorly, you start with the lienorenal ligament.
Okay, we said we have many questions about this one. We have two ligaments, gastrosplenic and lienorenal ligament. Okay, gastrosplenic, the most anterior. You have to open to approach the hilum of the spleen. You have to open to approach the lesser sac and the hilum of the spleen. The most posterior is the lienorenal ligament. You have to ligate and divide to mobilize the spleen from the posterior abdominal wall. Okay, what is the most common organ injured during splenectomy?
Tail of the
Tail
pancreas.
of pancreas.
Okay, in
Tail of
general,
pancreas.
most common during splenectomy, tail of pancreas. If he told you during lienorenal ligament division, it will be
Tail of pancreas.
tail of pancreas. If he told you during the gastrosplenic ligament division,
Fundus of the fundus.
fundus of the stomach. Clear?
Yeah.
Okay.
Sir, last point, could you please repeat that, related to fundus of the stomach?
This is the gastrosplenic ligament, and this is the stomach, and this is the spleen. This one you have to divide to reach the hilum of the spleen and the lesser sac. This is the one you have to divide first. During exploration, you pull the fundus of the stomach to outside and start to put two clamps here to divide in between. So you have to divide the gastrosplenic ligament and then invert the stomach so you reach the hilum and you open the lesser sac and to reach the the lienorenal ligament. Okay, so this is the first one. During this division, you can injure the fundus of the stomach because it contains the short gastric vessels.
Yes, sir.
Clear? Short
Yes, sir.
gastric vessels, and you can injure this because during splenic hematoma, the hematoma almost will cover this place. You will find when you open patient with splenic hematoma, this peritoneal fold is like this. So you hardly can put with your hand to determine the edge of the spleen and the edge of the stomach, and you almost come direct here. Yani, no problem to cut part of the spleen, not to injure the stomach. Clear? After opening this, you went back here. So you are going to divide the lienorenal ligament to mobilize the spleen from the posterior abdominal wall because this is a posterior abdominal wall ligament. So you have to divide this. During division of this, what it contains? Splenic vessels. And what else? Tail of pancreas. So you can injure the tail of pancreas. Okay, so during the gastrosplenic ligament, we can injure the fundus of the stomach. During lienorenal ligament, we can injure the tail of pancreas. Clear?
Yes, sir.
If in general ask about the most common organ injured during splenectomy, it will be tail of pancreas in general, and he didn't determine any ligament. Next question.
A 45-year-old man has established post-hepatic cirrhosis. At a follow-up appointment, a palpable spleen of 4 finger breadths below the costal margin is noticed. Full blood count has shown a persistent thrombocytopenia. Bone marrow examination has shown megakaryocytic hyperplasia. What is the most likely cause for the thrombocytopenia? This is hypersplenism, so it's platelet destruction in the spleen.
Exactly. We said this, we have to think about spleen and platelets. Enlarged spleen, thrombocytopenia. Splenectomy, thrombocytopenia. Splenectomy,
Thrombocytosis.
post-spleen, thrombocytosis. Clear? Patient after splenectomy, the most common blood picture will be thrombocytosis. Patient with hypersplenism and the blood picture is thrombocytopenia. Why? Destruction of the platelets by the spleen. Next.
129. A 7-year-old boy presents with recurrent attacks of pneumonia. Culture showed Pseudomonas aeruginosa. His mother confirms that he had meconium ileus in the neonatal period. Which of the following is the most likely finding in this boy? This one, picture of cystic fibrosis with abdominal cilia movement. Your diagnostic test will be chloride sweat test.
Sweet
To
chloride
be
test.
increased.
Increased sweet chloride test. Patient with meconium ileus and recurrent attacks of pneumonia. Very common question in the exam. This is increased sweet chloride test. Increased sweet chloride test. Okay, meconium ileus, recurrent attacks of pneumonia, sweet chloride test. This is the very common and most common scenario will come to you. Next question.
A 42-year-old woman has a cholecystectomy and develops a self-limiting post-operative wound infection. By what process would bacterial ingestion have been enhanced? Apoptosis, autophagy, metaplasia, opsonization, and phagocytosis. It's opsonization.
Opsonization by macrophagy, and this is the most common also. This question is repeated every 2 times per year by this order. Okay, next question.
After resection of a rectal tumor, a patient experiences erectile dysfunction. Which of the following nerves is the most likely to have been damaged in surgery? This one explained yesterday, I think. It's pelvic splanchnic nerve, or other name is hypogastric nerve.
Hypogastric or pelvic splanchnic nerve. Hypogastric plexus. Sometimes it's hypogastric plexus. Here is like hypogastric plexus, or you have superior hypogastric. Don't forget about it. It's pelvic splanchnic. You mostly go with pelvic splanchnic nerves. If you didn't find, go for hypogastric plexus. Hypogastric plexus, if you didn't find. Okay, inferior hypogastric plexus. This all makes up plexus here. Splanchnic nerve and inferior hypogastric plexus, always damaged during rectal surgery or sometimes during prosthetic surgery. Next question.
A 15-year-old girl has been treated for tuberculosis over the previous 6 months. She presents to the doctor with fatigue, loss of appetite, and loss of weight. On examination, her blood pressure is 90/55 and has increased pigmentation. What is the next most appropriate investigation? So I think she's in Addisonian crisis. So ACTH stimulation test, this one, with the scenario given a pigmentation and hypotension.
Exactly. Hypotension pigmentation, as we said yesterday, this patient with Addisonian disease or Addisonian crisis, what you give this patient to do ACTH, diagnosis of Addisonian crisis by ACTH stimulation test. ACTH stimulation test. Okay.
Okay. A 73-year-old man with a history of irregular bowel movements presents with dysuria, pneumaturia, and E. coli urinary tract infection. CT scan shows a mass involving the sigmoid colon and the bladder. What is the commonest cause of this presentation? This one, I think we discussed
Repeated
also.
yesterday.
Yeah.
Repeated
First
yesterday.
paper.
Okay, and we said that the most common cause of
fistula.
Okay, and the most common cause of left iliac fossa pain in old age will be diverticular disease. Diverticular disease with its complication, with history of chronic constipation as well.
A 30-year-old man is assaulted with a hammer and sustained a depressed fracture at the vertex of the skull. Profuse venous bleeding is noted at the fracture site. Which vascular structure is most likely to have been perforated? A. Cavernous sinus, inferior sagittal sinus, sigmoid sinus, superior petrosal sinus, and superior sagittal sinus. So from the vertex is only superior sagittal sinus.
Okay, this is the anatomy of the superior sagittal sinus at the vertex. So any fracture here will cause bleeding at the superior sagittal sinus. Okay.
57-year-old heart transplant recipient is keen to join the cardiac rehabilitation program. Which of the following factors is most likely to increase cardiac output in this patient during moderate exercise? This one is repeated also. I think the
Repeated
answer
also,
is
increase
atrial.
atrial filling. Increase atrial filling. Patient with heart transplant, we have 2 questions about it. Okay, we have 1 question here, and the 1 question will be in April 2018, inshallah. We will, I don't want to mention all the questions. So this patient with heart transplant, and then patient with cardiac rehabilitation, and what is the most likely to increase the cardiac output for this patient? This is a vagotomized patient, so this will be increase the atrial filling. Increase the atrial filling. This question will come in the exam, come with this scenario and with this choice with the same, mostly with the same order of the exams. Okay. So in the exam, you didn't read this. You will search direct for increase the atrial filling.
Okay. 136. An 18-year-old woman fell 9 meters while rock climbing. She had a renal transplant 2 years ago. She is brought to the emergency department for resuscitation and appropriate analgesia is given. When correctly prescribed, which of the following analgesic drug will be the most likely to adversely affect her renal function in this situation? A. Diclofenac, B. Dihydroxychloroquine, C. Morphine, paracetamol, and tramadol. I think it's NSAIDs. You don't give it in post-transplant
We don't
patients.
give NSAIDs. Exactly. We don't give NSAIDs. We don't give NSAIDs for patient with renal transplantation. Okay, it's contraindicated to give this patient. Yeah, this is a summary why we don't like, or even patients who take analgesic for long time and for high doses, why they sometimes get an acute renal failure or renal problems, because the afferent renal vessels depend on prostaglandins to keep dilated. Much administration or much ingestion of non-steroidals and diclofenac, non-steroidal will abolish the action of prostaglandin, and so will be vasoconstriction of the afferent blood vessels of the kidney, and this will decrease the blood supply and renal perfusion and glomerular filtration rate for the kidney, and it will be harmful to the kidney and can predispose to acute renal failure if in high doses. Clear? Non-steroidals abolish the action of prostaglandins that normally makes the afferent arteriole of the Bowman's capsule or the glomeruli open and patent. So this is normal, and this is reduced glomerular filtration rate due to non-steroidals. Okay, continue.
A 77-year-old man is admitted with acute urinary retention secondary to benign prosthetic hyperplasia. A urinary catheter is inserted and has free flow of concentrated urine. Which of the following best accounts for the action of countercurrent multiplier mechanism that leads to the concentration of urine in the loop of Henle? A. Active transport of solid out of the thin section of ascending limb, impermeability to water in thick ascending limb, permeability to solute in descending limb, permeability to solute in thick ascending limb, and permeability to water to thin section of ascending limb. And out of all this, I think it's
Okay,
just
this question is very hard question. Even I send it for many physiology friends teaching for physiology. Many of my friends and to MRCP friends, and even those who are teaching MRCP, and there is confusion between this question about these two answers, this answer and this answer. Okay, both these answers are confusing because what will happen? What is the counter current multiplier mechanism? It is the mechanism by which concentration of urine happens. The mechanism by which concentration of urine happens. What happened during this mechanism? Okay, what happened to this mechanism?
solid is
Okay. During descent of yes, during descent of plasma here, there is free permeability of water in the descending limb of lobe of hand. Okay, clear? Free permeability of water. During ascending, there is impermeability to water, but there is active transport of solutes. There is active transport. You see these circles? Active transport of solutes. So the active transport of solutes will make the tonicity here is high. Yes? And then when urine is coming here, and you will find the tonicity in the medulla is high, there is free water permeability, and so on. This is circle. Plasma come here, urine come here, water go out, concentration, and then go up again. No water go, but active transport of solutes to make the tonicity here high, and then the tonicity will make absorb water, and so on. This is the mechanism. Here we have to answer impermeability to water in the thick ascending limb. Completely right. Completely right. Okay. Even in the word impermeability. C, D, permeability to solute in the thick ascending loop. It is right, but it is more accurate if he said active transport. Active transport. Okay, why? Okay, doctor, permeability can equal free transport, active or passive transport. No, if it is equal to it, why in the first A he said active transport of solute out of the section of ascending limb? Okay. Still, we have debate about this question. You have to read about, I'll send you some picture about current mechanisms, but concentration of urine, okay, mainly by impermeability of water through the ascending limb of lobe of head, okay?
okay.
Impermeability to water to the thick ascending limbs. Others say permeability to solute in the thick ascending limb of hair. This is, by the way, sin, and this is completely wrong. But here is, he said active transport, and then here is sin. And then he said permeability here, and said sec. Why he didn't say active transport in the sec? This will be right. But here, this sentence is completely right. Impermeability to water in the sec ascending. There is no permeability of water here. Clear? Anyone search about it? And answer me if he could reach an answer. But for me, this is the completely right.
Yes, the thick in the thick ascending limb, urine is highly concentrated.
Okay. Why? Because permeability to solute or impermeability to water, both of them are right, by the way. But this should be changed to active transport. Because he already wrote active transport up. He said active transport and sin. So those who say, okay, permeability equal passive and active transport, okay, that's why he didn't, why here he didn't say permeability. So all will be permeability. He can easily say here permeability of solute out of sick, so it is completely wrong. Permeability can be right, but he said here active transport, and this is the only step active transport that happened during the counter current mechanism of urine concentration. Clear? Think about this. For me, my answer is impermeability to water and sick ascending limb. This is how to count current mechanism and concentration of urine. Next question.
Okay. A 52-year-old man undergoes a 52-year-old man is found to have multiple myeloma. What skull X-ray appearances would be characteristic? A, diffuse thickening. Yeah, I think this one is multiple osteolytic lesions, punched out skull.
Okay, this is from yesterday, multiple osteolytic lesion. Next question.
A 56-year-old man undergoes resection of his ileum secondary to ischemic bowel. Which of the following effects is most likely to be seen in this patient post-operatively? A, decreased bile salt synthesis by liver, no. Decreased concentration of bile salt in colonic content, no. Decreased mean corpuscle volume, D, decreased reabsorption of B12, and D, decreased stool frequency. It's B12 reabsorption. It's mainly in the terminal ileum.
Decreased reabsorption of vitamin B12. Vitamin B12 is one of the main that happened during resection of the terminal ileum. Okay.
Next question. A previously healthy 45-year-old woman undergoes emergency splenectomy following traumatic rupture of the spleen. A left subclavian central venous pressure line is inserted to guide fluid therapy. At this time, she becomes distressed and acutely dyspneic with a blood pressure of 75/40. There are decreased breath sounds on the left. Her temperature is 35.5. Most likely cause CVL insertion will be tension pneumothorax.
Tension pneumothorax. Tension pneumothorax. You see here, patient is hypotensive and decreased breath sounds. So this is tension pneumothorax. He mentioned nothing about the jugular venous pressure, but as we learned from the previous question, that if I have a patient with hypotension and decreased breath sounds, and this is the most of the very common complication of CVP, that the patient can have hemorrhage or can have tension pneumothorax. That's why after CVP, all patients are prone to chest X-ray. Okay, after CVP, most patients are prone to make an X-ray chest to make sure there is no pleural injury and the patient does not have intention. Okay, next question.
During the second proliferative phase of wound healing, the predominant cells in the wound site are fibroblasts. This cell is of mesenchymal origin and produces matrix and collagen needed to strengthen the scar. Cross-linkage of collagen requires hydroxyproline and hydroxylysine residues, which requires a specific vitamin to be available in sufficient quantities. Which vitamin is vitamin C?
Vitamin C. Cross-linkage of collagen needs vitamin C. Next question. And by the way, as I for memory, for new members, we said you have vitamin A, okay, sorry. We said most important, we have vitamin A, vitamin C, vitamin B1. Patient with cloudy eyes. Okay, I will give after this next question, by the way, without you saying. Okay, I'll give break immediately after the last question. Okay, patient A, cloudy eyes or night blindness. This patient vitamin A deficiency, vitamin C, he will tell you about collagen cross-linkage. Collagen cross-linkage, and if sometimes give patient about neurological problems. Neurological problems, he will ask about B1 or thiamine. Okay, or C or ascorbic acid, or vitamin A, retinoids, but he will not ask you, he tell you vitamin A only. Here he tell you vitamin C. This is the most common vitamins he will ask you to solve. Next and last question before break.
Okay. A 19-year-old man fell down a flight of stairs. On presentation to the emergency department, his GCS was 14/15 with no neurological signs. An hour later, he vomited and his GCS deteriorated to 10. He developed a fixed and dilated left pupil. Which of the following is likely to be seen on the scan? Since he had a lucid interval in between his consciousness, I think it's EDH. And then fixed left-sided pupil, so it's left side.
So it is left-sided extradural hematoma. Okay, the extradural hematoma gives initially symptoms on the same side. So it compressed on the same side and cause the left-sided extradural hematoma can go left-sided fixed dilated pupil. Why fixed dilated pupil? Because compression of
Oculomotor.
Oculomotor nerve. Oculomotor nerve carry
Parasympathetic.
oculomotor nerve carry parasympathetic fibers. So there will be
And of course, action of the sympathetic.
Perfect. So compression on the oculomotor carries the parasympathetic fibers, and the parasympathetic, so it will be overactivity of the sympathetic or unopposed sympathetic stimulation. Okay, back again after break. Start with question 143 with Dr. Wahiha. Okay, doctor, you can start.
So start.
Yes.
A 70-year-old woman weighing 50 kgs undergoes open cholecystectomy. Post-operatively, pain relief is administered by intravenous morphine infusion. Morphine 1 milligram, 5 minutes lockout. 24 hours post-operatively, she's in an agitated, confused state. Her temperature is 37.1 degrees centigrade, pulse was 90 beats per minute, and her blood pressure is 110/80. Her urine output is 35 ml per hour. ABGs are pH is 7.27. Partial pressure of carbon dioxide is 10 kilopascals. Partial pressure of oxygen is 9.6 kilopascals. Bicarbonates is 36 millimole per liter, and the base X is of -6. Which of the following is
Okay.
most likely the explanation to the account for false findings? So the answer here is opiate-induced hypoventilation.
Opiate-induced hypertension. Okay. This patient has, what's your comment about her ABG?
Sir, it's acidosis.
Okay.
Seems to be like metabolic acidosis.
It's respiratory acidosis, partially compensated.
Okay. What is the pH?
Towards the acidic side?
pH is acidotic, yes. And CO2 is acidotic.
On the higher side. Yeah.
But bicarb is alkalotic. So what comes
Yes.
with the pH is the respiratory parameter.
Yes. Okay,
So
so
this
respiratory
respiratory acidosis. And I have here metabolic compensation, but it is partial compensation. What does it mean? As we said yesterday and the day before yesterday, what does the patient has?
The condition.
A metabolic, this patient has a chronic condition. So this patient is a COPD, mostly COPD patient, chronic patient COPD. Okay.
Yes, sir.
So this patient has a respiratory acidosis, and this patient took intravenous morphine, which increase and makes hypoventilation and depress the respiratory center in this patient. So this patient went for more respiratory acidosis. You know, this patient normally you can find it maybe 7.36 because compensation doesn't cross the 7.4. This patient in the normal situation, you can find here ABG 7.36 or 7 because compensation is start to work till it cross the 735 and go in the safety period or the safety range and then stop compensation. So this patient, as the patient is took morphine infusion, so this makes depression of the respiratory center and makes hypoventilation. So opiate-induced hypoventilation is the main cause of her problem. Okay.
Yes, sir.
If you went for other answers, what you'll see? Okay, this patient has hypovolemia. Nothing here. Blood pressure is good and pulse is good. Pain-induced hyperventilation. No, the patient is already on morphine. Why pain? Pulmonary embolism. This is not the picture. What is the ABG picture of pulmonary embolism?
Pulmonary embolism, there is respiratory alkalosis.
Respiratory alkalosis and tachycardia and hypotension. Tachycardia and hypotension. Silent MI, we don't have any silent condition in our MI. Yes, and we don't have any silent condition in our MRCS study, and we don't have any infarction. This is an MRCP question. So this question is very simply, this is morphine or opioid-induced hypoventilation. Next question.
Yes,
this
sir.
Repeated question from yesterday.
Yes.
From Fawzia sheet 1.
Yes, sir. 70-year-old woman from nursing home is brought to the emergency department with abdominal pain and vomiting. On examination, she is dehydrated and her abdomen is distended. There is 3 centimeter into 4 centimeter swelling in the right groin. which is non-tender, and there is no cuff impulse. At operation, the femoral hernia is found. Which one of the following lies immediately lateral to the hernial neck? So the answer here is femoral vein.
Femoral vein. Boundaries of the femoral triangle or the
Yeah.
femoral ring is very, very important. Very, 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 very important. You have 1 or 2 questions in the exam. Okay, as we said, the medial boundary is the lacunar ligament. The lateral boundary is the femoral vein. The posterior boundary is the pectineal ligament, and the anterior is the inguinal ligament. Okay, very, 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 very important. 1 or 2 questions in the exam. By the way, you can expect all the 70-80 questions will come in the exam from anatomy. You can expect them if we start to enumerate. We can get more than 70% of the first paper. That's why I'm telling anatomy questions, yani, there is no chance to get anyone wrong. All are very easy and all simple and straightforward. Okay, continue.
A 64-year-old woman is reviewed in an emergency department with an acute right groin swelling below and lateral to the pubic tubercle. Which of the following forms the medial boundary of the ring through which this hernia is protruding? So the answer here is the lacunar ligament.
Lacunar ligament. Okay, medial boundary of it is the lacunar ligament. Okay.
So in the previous question, you told that the femoral triangle and what else is very important?
Sorry, the boundaries of the femoral ring. The femoral triangle, and we may have 1 question about it, but femoral ring is very, 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 very important, more than you imagine.
Okay, sir.
Okay. Next question.
A 27-year-old has had pancolitis for the last 5 years. Which of these is the complication is the least likely to develop? So as we discussed previously, since it's pancolitis, it is the arthritis, cholangitis, iritis, all is possible except polyarteritis. So the answer here is
polyarteritis, very important. Polyarteritis, no arterial inflammation or pathology in inflammatory bowel disease. Don't confuse between iritis and arthritis. Sometimes he tell you polyarteritis to confuse you more, and in the stress of the exam you'll get confused. Polyarteritis is not included in any inflammatory bowel disease. Next question.
An 82-year-old woman had a hemiarthroplasty of the hip 6 hours ago. She's an insulin-dependent diabetic and has been on a long-term non-steroidal analgesic. In the last 3 years, she passed through her urinary catheter a total of 20 ml of urine. Her pulse is 120 beats per minute and regular. Her blood pressure is 100 per 60 milligram of mercury, and the capillary refill is 3 seconds. Her urea electrolytes levels are sodium is 135 millimole per liter, potassium is 4.0 millimole, whereas the creatinine is 140 micromole per liter, and the urea is 20 millimole per liter. The most likely cause of this is reduced renal perfusion.
Reduced renal perfusion. The other question, which is confusing to all since 2016 till now. This woman is an old woman and she has a hemiarthroplasty. She is in insulin and has been on long-term non-steroidal analgesic. And we just said what is the problem of non-steroidal on patients. And she is diabetic patient. She has diabetic nephropathy, diabetic arthritis, and she has multiple comorbidities. age, diabetic, and so she expected to have a renal insult, and she is taking long-term non-steroidal anti-inflammatory drug. So the patient has decreased renal perfusion normally. In the last 3 hours, she passed via her urinary catheter a total of 20 ml per urine. Okay, and this is very minimal amount. She is passing very few amount of urine.
Yes, sir.
Her pulse rate is tachycardia. This patient is tachy. And her blood pressure is low. This patient is low, and the capillary refill is 3 seconds. Capillary refill is almost good. يعني or at يعني 3 seconds. يعني the borderline between the normal and starting to have decreased perfusion. What do you expect this patient to have? Okay, acute tubular necrosis. No, the patient has a kidney insult here. Okay, kidney insult. Why is this kidney insult? Is it due to acute tubular necrosis? No. Blocked catheter? No. Blocked catheter will give us 0 urine. Diabetic nephropathy? Maybe, but it doesn't explain why tachycardia and low blood pressure. Okay.
Yes, sir.
Non-steroidal. So non-steroidal afferent vessel vasoconstriction, so it will not also explain the hypotension and tachycardia. Okay.
Yes, sir.
Does not, but the only one can explain this is the reduced renal perfusion. Decreased renal perfusion can happen due to hypovolemia. Okay, so this patient may be hypovolemic, and hypovolemia can explain for us the low blood pressure and the tachycardia. Yes?
Yes, sir.
Okay. Hypovolemia, so the patient has tachycardia, low blood pressure. The patient will have antidiuretic hormone will start to act to decrease urine secretion. Will be concentrated urine, low amount, and at the same time the patient has a high urea and creatinine because of she has diabetic nephropathy. The patient has non-steroidal for a long time, so normally this patient can, plus the hypertension or the hypovolemia, she can have also reduced renal perfusion. Okay, clear why did we choose this one?
Yes, sir.
Okay, all of this can do this problem, but the first two can't explain why tachycardia and hypotension, except the last one. Okay, next question.
Which single respiratory test parameter, FE1, force expiratory volume in 1 second, FVC, force vital capacity, is the best prediction for morbidity and mortality after surgery? First is the confronted flow volume loop. Second is FEV1, which is less than 1 liter. FEV1 over FVC less than 70%. D is the maximum inspiratory volume less than 2 liter, and E is the reduced residual volume. So the answer here is FEV1 less than 1 liter.
This question was answered, this one, for many years. Till last year, I corrected from one respiratory consultant starting from September 2020. And it was the first course I shared to give. And when I tried to correct all the question of Fawzia sheet, starting by Fawzia sheet, I found this question is completely wrong answer, unless it came about 2 times after Fawzia sheet. And by the way, it came, I think, in September 2020. The best prediction for morbidity and mortality in patient after surgery the FEV1 forced expiratory volume in 1 second less than 1 liter. This is the most predictive value about the patient morbidity and mortality. Okay, and even this said when we see a patient with COPD or chronic obstructive pulmonary disease, and this patient is consulted for preoperative evaluation, sometimes we do this test to make sure about the post-operative morbidity and mortality. They do this test, forced expiratory volume in 1 second. If it is less than 1 liter, the patient has a high risk of morbidity and mortality. Okay, why is this strong? FEV1 and FVC less than 70%. Mostly this one, FEV1 and FVC less than 50% will be high risk. You see, high risk, it will be less than 50%. Okay, so this don't try. By the way, most physiology question don't try to understand except few questions, because you have question from every branch not related to other questions. Okay, FEV1 less than 1 liter is the most predictive value. Next question.
A 58-year-old man admitted for inguinal hernia surgery is found to have enlarged heart shadow on his chest radiograph. Which one of the following statement is true of the right ventricle? So its answer is directly related to the diaphragm.
Exactly. We just need the true one. Okay, just need the true of the right ventricle. It lies directly on the diaphragm. Lies directly on the diaphragm. Okay, continue next.
A 67-year-old man is admitted to hospital for investigation of irregular heartbeat. The conducting system of the heart includes which of the following anatomical structure? So the answer here is AV node.
AV node. Okay, AV node, SA node, and Purkinje fibers are the conducting system. From all of this, you have only the AV node. Okay, next question.
A 28-year-old man is found in the sea by the emergency services. He is alert but confused. His core temperature is below 33 degrees centigrade. ECG changes that may occur include which one of the following? A is atrial flutter. B is inverted T waves at the junction of QRS and T wave. C is narrow QRS complex. D is prolonged PR interval, and E is shortened QT interval. So the answer here is prolonged PR interval.
Okay, this is a case of hypothermia.
Yeah.
Okay, and this is prolonged PR interval. Prolonged PR interval. What another thing is pathognomonic for hypothermia?
Postborn waves.
J wave.
G wave. Perfect. G wave. I'll send you to Osborne wave or G wave is the pathognomonic for, just wait, okay. Pathognomonic for hypothermia. Okay, I sent to the group. Very important, because many times in the exam you will find G wave. So prolonged PR interval and G wave or Osborne wave. Osborne wave. Okay, very important.
Yes, sir.
Next question.
A 75-year-old woman presents to the outpatient department with the 3-month history of painless ulcer on the sole of her left foot. On examination, she is obese and 1.5 centimeter deep ulcer over the first metatarsal head. His foot is warm and pedal pulses are palpable. She has hemoglobin of 13 gram per deciliter, normal urea electrolytes level. What is the most likely cause of her ulcer? So the answer here is diabetic neuropathy.
Diabetic neuropathy. Okay, so ulcer, painless ulcer on the sole, left on examination. So this is so neuropathic ulcer, neuropathic ulcer. What is the difference between the 3 ulcers is very important. Arterial ulcer is always painful and on bony prominent. Bony prominent. Okay. Venous ulcer, mostly on the medial aspect of the leg, gyrotous area. Okay. And the patient has a picture of chronic venous insufficiency and the bluish discoloration sometimes, or history of DVT, or a spider nevi, or spider nevi of the first stage of the varicose vein or dilated varicose veins on the lower limb, dusky leg coloration, pigmentation of the leg, which is dermato, and thickening of the skin, dermatosclerosis, and so on. This picture of venous ulcer. Okay, arterial ulcer patient has a peripheral arterial disease, smoker, burger disease, or something like this, and has a painful ulcer over bony prominence. Sometimes on the dorsum of the foot, sometimes on the ankle, sometimes dorsum of the foot, sometimes on the one of the malleoli, but painful is the pathognomonic for it. Neuropathic ulcer on the pressure area, and the patient has no pain, and the patient mostly diabetic patient because of peripheral neuropathy. 1 minute.
A 75-year-old woman. Okay, sorry.
Just a minute, please. And just not to forget this picture. Very nice picture to recall. Okay. Okay, so this is the hypothermia picture, J wave or prolonged PRQRS and the QT interval and so on. Next question, repeated from yesterday from Fawzia sheet 1.
A 24-year-old.
No, not repeated. This is different. The other question I told you about. Okay.
A 24-year-old man is assaulted and sustained a deep 2 centimeter long laceration to the lateral aspect of lower leg. Physical examination shows that the laceration is anterior to the lateral malleolus. Which of the following structure is most at risk of being divided? So the answer here is the superficial peroneal nerve.
Okay, what was the last question, the previous question?
It was like
behind the
yeah.
Okay, fracture, posterior malleolus. This is posterior malleolus, something like posterior malleolus here. Forget about it, but this is fracture, posterior malleolus, whatever he told you, approach, incision between fibula and tendon Achilles. sorry, between fibula and tendon Achilles, there is an incision. What is the most common structure can be injured is sural nerve. So he tell you the fibula or the lateral malleolus. Between it and the tendon Achilles, you have the sural nerve you can injure. And I told you in front of the lateral malleolus, in front of the lateral mass, the superficial peroneal nerve is the most common or one of the nerves that can be injured in this approach. Clear the two questions?
Sir, in front of lateral malleolus is the superficial peroneal nerve, and the other one that you mentioned, could you please repeat
Sural.
that? Sural nerve is for
Sural, this is the lateral malleolus. Between the lateral malleolus and tendon Achilles, you have the sural, and in front of the lateral malleolus, you have the superficial peroneal.
superficial peroneal.
Superficial peroneal. Okay. So
Yes, sir.
incision between the lateral malleolus and the tendon Achilles posteriorly, sural. In front will be
Superficial peroneal nerve.
superficial peroneal. Okay, this is a two question in this area.
Yes.
Okay.
A 48-year-old woman presented to the emergency department with persistent diarrhea. On examination, she was apyrexial and had an irregular pulse of 140 beats per minute. The most likely cause of abnormal cardiac rhythm is, so the answer here is hypokalemia.
The answer is
Hypokalemia.
okay. Persistent diarrhea, the patient
Yeah.
goes potassium, the same like persistent vomiting, hypokalemia.
Yeah.
Okay, next question.
A 45-year-old woman is investigated after 2 episodes of renal colic. A plain abdominal X-ray reveals small opacities in both kidney. No abnormalities are found on physical examination. The biochemical investigations show adjusted calcium is 2.85 millimole per liter, whereas the phosphate is 0.70 millimole per liter. Alkaline phosphatase is 195 international unit per liter, whereas the creatinine is 72 micromole per liter, and the parathyroid hormone is 12.7. So which of the following is most likely cause? So the answer here is the primary hyperparathyroidism.
Primary hyperparathyroidism. Okay, what's the parameter? Why did you choose primary hyperparathyroidism?
So because the calcium is raised and along with the parathyroid hormone.
Okay.
But I'm not sure about the alkaline phosphatase as far I remember. So that alkaline phosphatase is usually high in tertiary hyperparathyroidism.
Yes, but here is high, but you have two things important here.
Yeah.
High parathyroid and then high calcium.
Yes, sir.
Okay, what will happen in secondary?
In secondary, we usually have the increased parathyroid hormone along with increased phosphorus, whereas the calcium level is on
due to
increase
I need
calcium
also you have to mention what is the main pathology.
main pathology is increased calcium in the blood and
decreased calcium in the blood.
Decreased calcium in the blood.
Hypocalcemia, and we'll have
negative
feedback.
Yeah.
Negative feedback.
Yes, negative feedback.
Okay, negative feedback, so it will increase the sodium. And what is in the tertiary?
There will be
so renal transplant.
History of renal
post-renal transplant patient. Post-renal transplant patient, because there is already hyperplasia. And so the patient corrected the cause of calcium loss, which is the kidney, and decrease in the vitamin D. And this patient started to have normal calcium metabolism, but still he have hyperparathyroidism. So the patient will have a very high hyperparathyroidism, and hyperparathyroid hormone, and the patient will have high calcium and high phosphorus as well, plus high alkaline phosphatase, and this patient will mention this patient have a renal transplant or renal pathology. Okay.
Yes, sir.
Next.
35-year-old man develops septicemia following surgery for perforated acute appendicitis. He's hypotensive and her ABG is revealed. pH is 7.27. Carbon dioxide partial pressure is 7.5 kilopascals. Partial pressure of oxygen is 7.2 kilopascals, and the bicarbonate is 17 millimole per liter.
Comment on the ABG before you read the answer.
Okay, so pH is on the acidic side.
Okay.
And
CO2.
partial pressure, sir, it's towards the sir, acidic.
Mixed.
Okay. And bicarb is?
Bicarb is low, alkalotic. Sorry.
Bicarb is?
Acidic, sir.
Acidic. Bicarb acidic.
So
low
means,
bicarb means
it's
acidic.
on the low bicarb. No,
So
sir.
you have, what is the pathology you have?
Sir, respiratory acidosis.
You have
Metabolic
acidic pH and you have acidic CO2 respiratory parameter and you have acidic bicarb metabolic parameter. So what you have?
Next picture.
So mixed picture.
Mixed metabolic respiratory acidosis. Okay, then go to the question. Which of the following most likely explanation is compensated?
Yeah, no.
It is compensated.
No, sir.
It is uncompensated metabolic acidosis.
No.
It is uncompensated respiratory acidosis.
No.
So it is mixed. ABG question, if you answer it in your mind before reading the answer and you find your answer in the mind, you find it in the options, so 99% you are right. Don't read the answers before you put in your mind what is the ABG. This is a picture of the ABG you'll find in the exam.
So usually when there is mixed picture, I usually get confused in the mixed picture.
Why? Why get confused in the mixed picture?
So because if it's simple respiratory acidosis or
why you
metabolic
get, why you make yani, if you have
Yeah.
did you see our ABG lecture we did 2 weeks ago?
So yes, I actually I started it, but I haven't yet finished it.
Okay, you have to finish, because what we say
Yes, sir.
here, we say pH, here we say we make this table and we say pH, and we say CO2 and HCO3, and we say here acidic, we say here normal, and here we say alkalotic. Okay, and we say pH is acidic. Yes,
Acidic. Yes, sir.
pH is acidic, so pH is here, and go CO2 is acidic. Yes, here HCO3 is acidic, so it is mixed acidosis. Okay,
Yes,
if you find HCO3 is here, so this is respiratory acidosis. If you found HCO is here and CO2 is here, so it is metabolic acidosis. Okay,
Yes, sir.
clear? Go for the lecture.
Yes,
Mixed
sir.
means you have the post parameters. You have the pH acidic, and then go to the HCO3 and the CO2. So we have here acidic, and we have this acidic, and we have this alkalotic. So what matches? This matches, so this is wrong. So this is respiratory acidosis. if I have this alkalotic and this acidic. So this is not matching, this matching, so it's metabolic acidosis. So pH matches one, but if I found both of them metabolic or both of them acidotic, and I have here metabolic acidotic or alkalotic, so it will be mixed. Why mixed? The mixed, this is the most easy one of them. You don't have any confusion. Sometimes some people confuse between compensation. Okay?
Yes, sir.
Okay. Next question. Again.
Okay. A 75-year-old man is assessed for surgery. He has smoked 25 cigarettes a day for the past 45 years. He is short of breath on minimal exertion. A chest auscultation reveals a widespread wheeze. A chest X-ray shows hyperinflation of lungs. Her AB sample reveal.
What do you expect in a patient with hyperinfiltrated lung and widespread wheeze and patient smoker for 45 years?
COPD?
What do you expect? COPD. What's the picture of COPD you will find? What is the forget about this table? Patient of COPD. What is the EBG picture you have?
The respiratory.
You have the pH.
Compensatory
You have
picture.
You have the pH, and you have the CO2, and you have the HCO3. Yes. Comment the three. pH will be
acidic.
Why? Any chronic patient can stay for 45 years acidic?
No. It would be compensated.
COPD patient would be normal.
Yes,
because he is fully compensated. But you will find his pH about 36, 37, something like that. Yani hardly normal. And any problem like what we have, that the patient take morphine or hypoventilation, he will go direct to 7.33 or 7.32. He will go to the acidic side. Hardly neutral patient. Okay. What about the CO2 patient or the CO2 of this patient?
So it's high.
Will be
high.
High CO2.
Will be high. More than 6. More than 6.4.
More
than 6.
Respiratory inhibition.
And the HCO3 will be HCO3 will be in this patient. This is a chronic patient. HCO3 will be
raised
because of compensation.
Due to compensation.
Sir, high
will be raised. High. Almost more than 30.
Yes, sir.
Almost more than 30. And it is normal from 22 to 26. This patient. The picture of COPD, never forget in part A and part B. The patient will be normal pH because this is a chronic condition. Patient can't stay alive with acidotic pH for a long time. So normal pH, high CO2, and the high compensatory HCO3, and you'll find the CO3 very high, 36, 34, 35, something like this, because it is fully compensated respiratory acidosis. So if you put this in your mind, okay, you will go direct here. CO2 should be high. So I have 1, 2, all this completely wrong. I exclude from the first. Second one, bicarb fully compensated should be high. So this is right. Yes, others are completely wrong. You see? ABG question you have to solve in your mind before you start reading the answers.
Yes. Okay. Sir. Yeah. Thank you so much, sir.
Okay. Next question.
An 18-year-old woman present with recurrent tonsillitis and spontaneous skin bruising. On examination, there is no lymphadenopathy or splenomegaly. What is the most likely diagnosis? So A is acute myelocytic leukemia, B is agranulocytosis, C is aplastic anemia, D is Hodgkin disease, and E is human immunodeficiency virus infection. So the answer here is aplastic anemia.
Aplastic anemia. Okay, this patient, he told you, why? He no splenomegaly, no lymphadenopathy. Acute myelocytic leukemia, this patient will have lymph node and spleen. Agranulocytosis, why this patient has recurrent sinusitis, agranulocytosis, but spontaneous bleeding because of the low platelets. So you have two things here. You have low white blood cell, what means agranulo. No, not agranulocytosis. This is agranulo, should be penia, agranulopenia or leukopenia. This patient has spontaneous skin bruising, so this patient has thrombocytopenia.
Yes, sir.
Okay, so all this will happen only with aplastic anemia. Okay.
Yes, sir.
Next question.
A 62-year-old woman presents with a firm irregular mass in the upper outer quadrant of right breast. This is shown to be malignant on mammography and is fine needle aspiration and on FNAC. She is treated with wide local excision and axillary clearance. Which of the following histopathological finding would imply a better prognosis? So A is absence of HER2 amplification, B is Bloom and Richardson grade 3, C is more than 3 positive axillary nodes, D is a presence of lymphovascular invasion, and E is the presence of estrogen receptors. So the most indication towards the better prognosis is the presence of estrogen receptors.
Okay, as we know, in breast cancer, favorable prognosis ER or PR receptor positive. Okay, and HER2 receptor negative. This is the best prognosis, but this is first and this is second. Okay, so this is presence of estrogen receptor is the best prognosis for patient for the you have mix, and you can find this positive and this negative. This is the best prognosis. The next one is all positive. The worst one is estrogen receptor negative and progesterone negative and positive HR2 are HER2 receptor positive. This is the worst prognosis. Continue, please. Thank you, Dr. Waliha. I was intended to make you read more and more, because many questions you just missing it. So I give you more opportunity to share with us. Thank you, and I hope Dr. Mahmoud, if he's ready. Mahmoud Sami.
Hello.
Are you here? Yes. Can you continue, please?
58-year-old man is due to have surgery for the duodenal contracture to release the ring finger of the right hand. Which one of the following regarding the anatomy of the ring finger is correct? Has cutaneous innervation from the radial nerve? It's the right answer.
Okay, this is the right answer. Read the other answers.
Has no cutaneous innervation from the median nerve. Wrong. Has no cutaneous innervation from the ulnar nerve. Has a flexor digitorum profundus inserting into the middle pharynx, distal pharynx. Is abducted by palmar interosseous muscle.
Okay, all is wrong except of this one. The middle finger has three nerve supply. Three nerve supply from the back, radial. From the front, he has medial and lateral by the median and ulnar nerve. And here, what is the palmar interossei do?
Adduct.
Palmar adduct. Dorsal interossei abduct. Okay. Pad and dab. I think you know pad and dab, yeah?
Yes.
Okay. Continue.
75-year-old man presents with deep vein thrombosis. Computerized tomography confirms the presence of thrombus in his common iliac vein, extending into the inferior vena cava. The common iliac veins join to form the inferior vena cava at which vertebral level? L5.
L5. This straightforward question. All anatomy questions are straightforward, and even in the exam, you will find no anatomy question new. Okay. Let's
35
revise also. Let's revise what is the formation of the aorta at which level?
Aorta
End of aorta.
formation,
Sorry, bifurcation.
End-
Bifurcation of the aorta.
L4.
L4.
Okay, bifurcation of the aorta is L4. Bifurcation of the carotid.
Carotid كان عند C6
C4. Okay.
C4.
Okay. C4. T4. L4. Bifurcation of the carotid. Bifurcation of the trachea.
Trachea.
T4, 5. Bifurcation of the aorta. Don't forget this.
Okay.
Clear? All bifurcation. Okay.
35-year-old motorcyclist is involved in RTA and fractures his temporal bone, completely transecting the facial nerve just distal to the geniculate ganglion. Which function of this nerve remains? Lacrimation, salivation from the submandibular gland, sensation to the anterior tongue, smile, taste. Lacrimation.
Lacrimation. Why?
Because
Here is a geniculate ganglia. Okay. And transecting the facial nerve just distal to the geniculate ganglia, preserving the greater petrosal nerve, which carries the pre-synaptic fibers of the parasympathetic supply to trigopalatine till the lacrimal gland. Okay.
Okay.
We have parasympathetic cranial nerve supply. We have 4, yes?
Yes.
We have 4. We have through the third cranial nerve, okay, to the ciliary ganglion. And this is the parasympathetic, which is compressed in extradural hemorrhage. And we have 2 through the facial nerve. And we have 1 through the which nerve? 9th cranial nerve. This is the parasympathetic. You have preganglionic fibers. Preganglionic. And you have postganglionic fibers. Okay. For this one, greater petrosal, preganglionic fibers, then trigopalatine ganglia, then go to the lacrimal gland. Okay.
Okay.
The other one is through chorda tympani to the submandibular ganglia to the submandibular gland. Okay, the last one is, I think this is through the lesser petrosal to the otic ganglion to the parotid gland through the auriculotemporal nerve. Forget about all of this. You have a question on this point. This one, distal to the geniculate ganglia, so you will preserve the greater petrosal nerve to the trigopalatine ganglia to the lacrimal gland, so the cremation will be preserved. We have another question in this point later, which the patient which will have a parotidectomy, superficial parotidectomy or total parotidectomy, and the patient then developed gustatory sweating due to mix between secretory and parasympathetic fibers during healing of the wound. So the parasympathetic fibers will regenerate in the secretory fibers. So during stimulation of the parasympathetic fibers, the gland start to secrete, on the sweat glands of the skin. So the patient will have what is called gustatory sweating. Gustatory sweating. This is the two questions important in this point. Will come later. Okay, continue. So you understand this?
Yes.
Okay.
30-year-old motorcyclist is brought to the ER after RTE. He has an open fracture of his right femur. On arrival, he is tachypnic and confused. Was cold and clammy skin. Which of the following physiological changes is most likely to be seen? Decreased reabsorption of water from the collecting tubules, decreased serum bicarb level, increased pH of blood, increased secretion of sodium in the urine, increased synthesis of glycogen in the liver. Decreased serum bicarb level.
Decreased serum bicarb level. This patient, you have to know what is the metabolic disturbance or what will happen to this patient. So this patient has an open fracture and arrived with tachypnic, confused, cold, calm extremity. So this patient will have metabolic acidosis, and he wants you to know what will happen in this patient. This will patient decrease the absorption of water. No, completely wrong. This patient will have renal angiotensin, water and sodium preservation due to stimulation of the renal angiotensin aldosterone system and antidiuretic hormone. This patient increased the pH. No, this patient will have decreased pH, increase the secretion of sodium. No, preservation of sodium, increase the sense of glycogen by episodes, the breakdown of glycogen in the liver. So this is the only one right here. Decrease serum bicarb level, because this is a case of metabolic acidosis.
Okay. 50-year-old man on the waiting list for a hip replacement attends the preoperative clinic. He has a body mass index of 41 and the risk of preoperative hypoxia. Reduction of which of the following volumes or capacities is the risk most likely to be due to? Expiratory reserve volume, functional residual capacity, inspiratory reserve volume, total lung volume, vital capacity. Functional residual capacity.
One of the very hard question. It takes me from about 1 week searching for this question to get the right answer for it. And I got it. This is a piece of an article, by the way. Okay, this question and discussed last 2 exams many times because it was answered expiratory reserve volume and some asking this vital capacity. But after you read this explanation, function residual capacity is the most likely risk factor in patient with intensive preoperative clinic. Body mass index 41. In obesity, body mass index, this patient is obese patient. So in obesity, the the most important thing, risk factor for this patient you have to measure is the functional residual capacity. Okay, someone can ask me, doctor, okay, why we don't, what will happen in this patient? Patient with obesity will have decrease in the respiratory reserve volume. This patient mainly will have decrease in the expiratory reserve volume. Okay?
Okay.
But functional residual capacity is expiratory reserve volume plus the residual capacity, the residual volume. So why we didn't say this only? Yani first, I answered this. But after I have read many articles, they only measure total functional residual capacity. Functional residual capacity is the main, and I contacted many of bariatric surgeons about this, and they told me the same. The most important surgery for doctors of anesthesia is the functional residual capacity of the patient.
But he mentioned here it's induction of general anesthesia causes a significant decrease in functional residual capacity. It will take spinal anesthesia, I think, for hip replacement.
For hip replacement, I know he can take spinal anesthesia, but sometimes if you want to give general anesthesia, whatever. We contact many consultants in this, bariatric and anesthesia and this, and then I could search for direct for all the articles. And this was an article, and I have on my big group, I have the full discussion, and I have the full article of this, by the way. I can send it to you. I have the full article of this. Okay?
Okay.
Functional residual capacity is the right answer. Continue.
A 4-year-old boy represented to the ER with a 2-day history of headache, vomiting, and drowsiness. CT scan reveals dilatation of both his lateral ventricles and his third cerebral ventricle. His fourth ventricle was of normal size. Suspected that he has an obstruction to his cerebrospinal fluid flow. To which of the following sites in the obstruction most likely to be cerebral aqueduct of Celebus?
Cerebral aqueduct of Celebus. This is repeated since Fawzia sheet 1. The most common site of obstruction is aqueduct of Celebus. Next question.
74-year-old man who has undergone emergency major abdominal surgery 2 days previously is noted to be confused. He has been on furosemide for mild heart failure. The plasma sodium is 122 millimole per liter. Inspection of the fluid charts show that he has been written up for 4 hourly IV 5% glucose infusions. What is the most likely cause for the hyponatremia? And ACTH response to surgery, excessive intravenous fluid administration, osmotic effect of hyperglycemia induced by glucose infusions, syndrome of inappropriate antidiuretic hormone, use of loop diuretics in the long term. I didn't get the idea.
You didn't get the idea. Okay. This patient went to the emergency and he did a major abdominal surgery 2 days. 2 days previous. He's noted to be confused and he has been on furosemide on mild heart failure. This patient is taking sodium lowering drug because furosemide increases the sodium excretion from the body.
Okay.
The plasma sodium is 122. Okay, so it is hyponatremia. Inspection of the fluid chart shows that the patient has written up 4 hourly IV glucose 5%. What is the most likely cause of this hyponatremia? Excessive administration of sodium-free fluid. What is your plan? What is your plan for a patient post-operative? What is the maintenance fluid for patient post-operative?
So 1 liter of saline, 1.5 liter of 5%
dextrose 5%.
This is the maintenance for patients. Sometimes in winter, in summer, we make this 2 liters. So 1.5 to 2 liters of dextrose 5%. This is the water for the patient. And 1 liter for saline, this is, you can expect, this is the nourishment and the food for the patient. Anything of this will not be given, the patient will have a big problem. If the patient took only saline post-operative, this patient will have hypernatremia, and the patient will be dehydrated because the fluid, the water the patient drink is dextrose 5%, as you are giving the patient no water for 2 days. And if you didn't give saline, the patient will go for dilution or hyponatremia. Okay, the patient will go for dilution. This patient needs about 2.5 liters to 3 liters per day. So this patient will go for dilution hyponatremia.
Okay.
Yes.
Yes.
So this is what he means, that excessive administration of sodium-free fluid or excessive intravenous fluid administration. This is dilution or hyponatremia. And the patient is taking furosemide, and the furosemide is losing. Can you remember furosemide? Where is the action of furosemide on the renal nephron, on the loop of Henle?
Thick ascending loop of Henle.
Thick ascending loop of Henle, and it lost how
One sodium,
how much
one
percentage?
25%.
Mechanism of action minus 25%, and this is the highest loss can happen from any loop diuretic. And what is the action of furosemide?
Sodium 2 chloride potassium.
Sodium potassium 2 chloride. So furosemide acting on the thick ascending loop of Henle, very important, very important. And forget about this, but I want to tell you that it is increase the loss of potassium loss of sodium up to minus 25%. So this is a strong antihypertensive, and it acts on the sodium potassium 2 chloride channels. Sodium potassium 2 chloride channels. Okay.
Okay.
You got this idea?
Yes.
Okay. Next question.
During arch aortography, the vertebral artery would be seen to arise directly from which of the following? Arch of the aorta, brachiocephalic artery, common carotid artery, internal carotid artery, subclavian artery. Subclavian artery.
Subclavian artery. Okay. Next question.
60-year-old non-smoker presents with 3-month history of loss of weight, malaise, and breathlessness. On examination, he has left supraclavicular lymph node enlargement. Chest radiograph reveals multiple bilateral opacities. What will biopsy of left supraclavicular lymph node most probably show? Chronic inflammatory cells, granuloma, Langerhans type joint cells, multiple abnormal mitotic figures in the cell, Reed-Steinberg cell. Multiple abnormal mitotic figures in cells.
Okay, what is this? He want to tell you, this is a pathology question, and he tell you this patient all the year, non-smoker, my loss of weight, malaise, breathlessness, on examination has left supraclavicular lymph. What is this?
Lung cancer.
Vertical lymph node. Vertical lymph node. So vertical lymph node. He just know here supraclavicular lymph node most probably show. He knows the pathology. What is the pathology? He just want this is a general pathology. Is there chronic inflammatory cells?
No.
Granuloma of chronic infection or chronic specific infection?
No.
The same like Langerhans. This is both of them are granuloma. Langerhans type of giant cells? No. Reed Sternberg cell of non-Hodgkin lymphoma?
No.
No. So this is, he wants you to know that in cancer, the cells has this feature, multiple abnormal mitotic figures, a feature of cancer cells, pure pathological, it has no relation of the history.
Okay.
Okay, last question, and then Dr. Hassini will take the last 7 or 8 questions.
12-year-old child was admitted to the ER having inhaled a peanut. Where will the peanut most likely to have lodged? Right lower lobe bronchus.
Right lower lobe bronchus. Very common, by the way, this question, right lower lobe bronchus, because it is indirect, more direct, straight continuation of the
Trachea.
trachea. Okay, thank you, Dr. Mahmoud. Go to Dr. Hassini. Dr. Hassini, can you continue the last few questions, please?
Yes, sir. 171. 39 years old multiparous woman who smokes 10 cigarettes per day, presents with 2 centimeter into 2 centimeter tender lump in her right breast. There is a brown discharge from the nipple. Mammography is unhelpful. An ultrasound shows some dilated lactation ducts. What is the most likely pathological diagnosis? A. Breast abscess. B. Fat necrosis. C. Fibrocystic disease. D. Phylloid tumor. So there are no symptoms of abscess, no history. So A and B excluded. Not fibrocystic disease. Ultrasound scan doesn't show any changes. Not that phylloid tumor. So it's plasma cell mastitis, which is also called mammary duct ectasia. Single dilated lactiferous duct.
If you find in the question a patient about 39 or 40 years, around 40, and she is smoker, and the question is about and the brown chart, and the question is about the breast, don't continue reading the question, really. Go direct for the answer, and you'll find plasma cell mastitis or duct ectasia, or sometimes, one time we found it subareolar abscess. But this is aseptic abscess, because he will tell you culture and sensitivity will reveal no gross. No gross. Will reveal no gross. Because of it is just plasma cell mastitis. Plasma cell mastitis. You have no question in the exam, patient 40 year. If he cancer patient, he likes to bring 50, 60, 70, something like this. But when he asks a 40 year and smoker, he wants you to correlate in your mind 40 year and the smoker patient will have a plasma cell mastitis or duct ectasia or subareolar abscess sometime. But if you found plasma cell mastitis, duct ectasia, you go for them in the first choice. No other question in the exam. Some questions in the exam, shabab, you have just to read 30, in my exam, 39 years old, multiparous woman, smoker, brown discharge. I didn't continue, okay. Plasma cell mastitis. This is the 10-second question in the exam. Okay, continue.
172. A 56-year-old man presents with headache and vomiting with deterioration over the last 2 weeks. On examination, he has papilledema. A CT scan shows a space-occupying lesion in the right parietal lobe. He develops a sudden homonymous hemianopia, which passed of the visual system to be affected. Which of the following visual systems to be affected? So it's parietal, affecting parietal lobe, and is also homonymous hemianopia. So it should be the optic radiation which goes through a parietal lobe and the temporal lobe. So the answer should be optic radiation.
Okay, where is the site of homonymous hemianopia? This is a homonymous hemianopia.
Oh, yes.
This is a homonymous hemianopia. What do you expect? Where is the lesion to be?
Homonymous and hemianopia, usually it's after the optic chiasma in the optic tract, either in the optic tract or after that, following that, through optic radiation and until to occipital lobe. But
from this to this, any fibers coming from here, even the fibers would here, you will go like this, and will go like this. Okay, so anything from the optic tract, optic radiation up to the occipital loop will give you homonymous hemianopia.
Yes.
Up to the occipital loop will give you homonymous because it will abolish all unilateral fibers supplying the eye. Clear?
Yes.
Okay. In the optic chiasma, what we will have?
Bitemporal hemianopia.
Okay, and the optic nerve?
It's
unilateral blindness.
Unilateral blindness.
Loss of vision in one eye.
One eye. Yes.
Okay.
Yes.
Clear?
Yes, sir.
Next question.
173. Atrial depolarization is shown by which ECG change? It's P. P wave is atrial depolarization, QRS is ventricular depolarization, T is ventricular repolarization.
And where is the atrial repolarization?
It's hidden in between QRS.
Hidden in the QRS. It appears here, but it is overlapped by the ventricular depolarization. Okay, next question.
174. A 65-year-old man with known ischemic heart disease and atrial fibrillation presents with the paralysis of his right lower limb. Which arterial territory is most likely to be involved? So it's right lower limb. It's upside down, so should be anterior cerebral artery.
Okay, and which one of the cerebral arteries?
Contralateral side of the brain that is affected. So left anterior cerebral artery.
So contralateral anterior cerebral artery. Contralateral cerebral artery. And we all know this is summary of the anterior and the middle and posterior cerebral arteries. And the most common in the exam, by the way. Most common in the exam, the anterior cerebral artery. And he will tell you he has more weakness in the limbs than the lower limbs than the upper limbs, because the body is upside down. And if he told you more in the upper limbs than the lower limbs, it will be
middle cerebral artery.
Middle cerebral artery, and he will tell you the patient have some sort of aphasia, perceptive aphasia or
Broca's and Wernicke's.
Broca's or Wernicke's aphasia. Okay, expressive or perceptive aphasia. In the frontal, by the way, and the anterior, the patient can be also present with some behavioral changes, because the anterior cerebral supplies the frontal lobe, and this patient can have some behavioral changes. So behavioral changes, weakness on the lower limb more than the upper limb, this is anterior cerebral. Middle cerebral, the patient will have weakness in the upper limb more than the lower limb, and we will have some sort of aphasia. Posterior cerebral, the patient was represented with some visual disturbance. And the most important one, very common in the exam, is the pica cerebellar. Pica, posterior inferior cerebellar artery, posterior inferior cerebellar, not cerebral, cerebellar artery, which will be represented with nystagmus, ataxia, sometimes nausea and vomiting, instability, and so on. Nystagmus, ataxia, nausea, instability. Sometimes this patient may have bulbar palsy. All these are pica. which is here. Okay. Very important, this diagram, by the way. Next question.
So it's 175. A 90 years old man who becomes hypertensive 2 days after total hip replacement. He is found to be in atrial fibrillation with a pulse of 140 beats per minute. After treatment with digoxin, his AF slows and he has a pulse rate of 90 beats per minute. Which form of the venous wave form is absent? So it's atrial fibrillation is atrial contraction is not properly happening. So in JVP waves, A wave is the one which shows atrial contraction. So
Okay.
A wave would be
Absent A wave. Absent A wave. And we said that for the GVP abnormalities, absent A wave, what is the most important?
Atrial fibrillation.
Most important questions you'll have: absent A wave in AF, and the other one, what is the C wave represent? Isovolumetric ventricular contraction. A wave and C wave are the most common question in the exam, accounts for 95% of all, maybe 100% of all question about GVP. Okay. A wave will represent atrial contraction and will be absent in AF. C wave represent tricuspid closure or isovolumetric ventricular contraction. Isovolumetric ventricular contraction.
Okay.
Next question.
176. A 56 years old man with chronic emphysema is on the high dependency
Okay,
HDU.
Stop. I'll hide the question. Okay, how to differentiate between mid-inguinal point and midpoint of inguinal ligament.
So midpoint of inguinal ligament is in midpoint between the pubic tubercle and the anterior superior iliac spine. Mid-inguinal point is the midpoint between anterior superior iliac spine and the pubic symphysis, which represents femoral artery. Mid-inguinal
This is femoral artery, and this is
deep inguinal ring.
Deep inguinal ring. Perfect. Best خلاص, I don't need this question. This is what we... Okay, read the question.
A 56 years old man with chronic emphysema is on HDU 10 days after anterior resection. He has developed acute shortness of breath and hypotension. Which of the following landmarks would be the most appropriate to use to obtain a femoral arterial blood gas sample? So it should be mid-inguinal point, which is midway between the anterior superior iliac spine and the pubic symphysis.
Perfect.
Answer B.
Excellent. Okay, last question.
177. A 45 years old woman with insulin-dependent diabetes attends to the ER with abdominal pain and confusion. She has been treated for 3 days with antibiotics for chest infection. Creatinine is 400 micromoles per unit and her blood gas sugar is 42 millimoles per liter. The most likely severe electrolyte abnormality is, so the patient is having renal function defects with this is millimoles, means hyperglycemia, 42, right? So it's diabetic ketoacidosis with hyperkalemia. Potassium is the abnormal thing that is seen with that.
This
so
patient will, this patient, blood sugar is 42. So I think it's very high. Okay, so you expect this patient to have diabetic ketoacidosis. The other thing is patient is chest infection, and the infection can give you metabolic acidosis. metabolic acidosis. So this patient expected to have hyperkalemia because in acidosis, the potassium will be high. In alkalosis, the potassium tend to be low. Okay.
Okay, sir.
Okay. Thank you. Today finished
Thank you,
Fawzia
sir.
sheet 2. Welcome. Not less than 40 to 50 questions will come the exam. I don't want to tell more, but not less than 40 to 50 questions of this recall. 2 recalls will come in the exam. And one of the friends who were Dr. Taki, Dr. Syed Taki, he is not with us today. And he said about 150 questions from Fawzia sheet came last exam. Okay.
Okay.
These Fawzia sheet, you have to know more than your names. Thank you for today. Go enjoy your day. Yes.
I have a question. There are so many physiology questions in here, and many of them which is relevant to the cardiology and the heart and lungs. Actually, they are difficult to understand. The mechanisms are. I find it a bit difficult to understand the mechanisms.
Yes.
Is it necessary to read?
No.
Or memorize the details, or I just the K point and answer, will that cover me in the exam?
Okay. For physiology. And physiology, if you found my plan since I started my free group about 1.5 years. For physiology, I keep recording for this. For physiology and pathology, you will not be able to cover all topics. Anatomy, we already covered.
Yes.
Okay, anatomy can be covered and already covered in our anatomy. Most question. But physiology, you have about 200 questions in MRCS.
Yeah.
And you have about 10 to 15 questions from every topic. You have respiratory. Most question maybe about 40 questions from respiratory and so on. And the others are just 10 to 20 questions. You will not be able to cover all physiology. If you want to cover all physiology questions, you need about 6 months to study. So what we do in physiology? In physiology, we study all the EMRCS plus all recalls. With your heart, you will get 95% of physiology question in the exam. In the exam, when he wants to give a new question in paper 1, he gives a new question in physiology and pathology. Sometimes it gives pathological picture for a tumor, pathological picture for any complication, for any pathology. Okay. And in physiology, just if any question you can't expect. You can't expect the picture question will be respiratory, or will be cardio, or will be renal, while the question will be metabolic and electrolyte, or will be blood. But how can expect? But there is main topics in everyone. Main topic in everyone. EMRCS question covers about 95% of all physiology questions. I have some videos I shared. Yani cardio, you have to know the GVP and the ECG, as we have in this exam. These and some other questions are very respiratory. You have to know all the respiratory volumes and the capacities. And I shared a video in this group, in the big group. In renal, you have to know the renal nephron and the mechanism of action of every mechanism and site of action of every diuretic. The most important, plus the countercurrent mechanism. Metabolic and ABG, very important to know the ABG and how to read ABG and the acid-base balance. For the blood, you have to know the coagulation cascade and some sorts of bleeding disorders. This is physiology. All this covered in MRCS. And after I finish, I'll send you the most important videos you have to see for physiology. I'll send it for you on the group from the big group. Okay? Okay. Thank you again, and wish you have a good night. Let's talk.
Thank you.
Thank you, Dr.